of infection and PHR.
Hello. हाँ क्या बोल रहे
So good morning, everybody. ये विजिबल नहीं है आपको तो कनेक्ट करो स्क्रीन told you we are not yet ready ऑपरेटर ने कहा आ जाओ तो सब चले आए शुरू करना है क्या कर रहे Right. So, good morning, everybody, and let's start this off with this diagnosis and prevention of prosthetic joint infection after total hip replacement. This lecture will be slightly theoretical because the whole basis is a bit theoretical. So I ask you to bear with me. And it is these X-rays which are a problem. If there is a frank infection and if everything is gone off, then it's very easy to diagnose. But the problem happens when the clinical symptomatology is out of proportion to what you see on his face. The patient says he has got a lot of pain, he's not able to walk properly. X-rays look plus minus. So that's where actually you need to make sure that this patient is actually not infected and is simply having loosening because of an aseptic process. So what we're going to learn here is just diagnosis, prevention, brief management, and how and what factors are going to make a diagnosis of prostate joint infection. So Vijay is an infection involving the joint process, or you know that, and adjacent tissue. The range is between 1 to 2%. This is Western literature, and I'm sure in India, Vijay is definitely more than 2%. So half of all my revisions actually right now are because of that. So that's I think and the reason is that we are doing joint replacement in facilities which are probably not as well equipped to do joint replacement, things like that. So we are not taking enough care with our patients, and we are getting a resultant infection. So the greatest risk period is the first 2 years, 60 to 70% of all these patients, and there is a very significant economic impact, which is up to 3 to 4 times that of the index surgery. So the patient has spent X amount on the index surgery, he will be probably spending about 3 to 4 times that for a revision of an infected joint. So early onset Vijay is less than 3 months after last surgery. Always the cause is an intraoperative contamination and fairly virulent kind of microorganism. Unfortunately, these microorganisms grow very nicely in culture. So it's very easy to diagnose early onset VI. The problem happens in delayed onset VI, which happens after 3 months, but before 2 years. Typically, these are also acquired at the time of surgery, and the classic organism for this is Tapeworm. This is a less virulent organism, sometimes difficult to grow in culture. So you need to have very good coordination between you and your microbiologist. Late onset PGI, of course, is after 2 years, and usually the cause is an madvenous bacteria. So, what are the criteria? So, there was a meeting in Philadelphia in 2018, which got the international consensus meeting. A lot of very famous joint replacement surgeons were there, including Janki, Yadav, Vijay, and all that. And they made a consensus on how to diagnose PGI. And the major criteria there were 2 positive periprosthetic cultures of phenotypically identical organisms. So if you get one culture Staph aureus and the other culture E. coli, that's not a major criteria. You have to get Staph aureus or E. coli in 2 subsequent cultures. And of course, the sinus tract communicating joint, these are just any one of these criteria is enough to diagnose. Any one of these major criteria is enough to diagnose PGI. But there are some minor criteria. Sometimes you're not going to get that. So some minor criteria also, which are elevated ESR and CRT, elevated synovial fluid WBC count on, or a positive change in leukocyte esterase. So it's increasing leukocyte esterase. Elevated synovial fluid neutrophils, positive histological analysis of periprosthetic tissue if you have taken biopsy from there, and a single positive culture. So any 3 of these can diagnose what are history and risk factors. So persistent pain or stiffness and any of the following. So patient has pain and stiffness and any one of these following. Repeated surgeries on the same joint. So I'm sure many of you must have revised simple failed neck femur osteosynthesis. And I have done a lot of them, and many times during removal of these implants, you get some funny type of fluid or tissue, which leads you to think that this might be probably infected and otherwise failed. So repeated surgeries on the same joint, history of prosthetic joint infection in the past, recent bacteremia, diabetes mellitus, steroid intake, frequent and dialysis, obesity, IV drug abusers, and superficial surgical site. So patient comes to you saying, sir, I had a joint replacement. Everything was normal. Everything is moving around, but the wound took a long time to heal. Nothing came out after that once it healed. But it took a long time to heal. So sutures were removed after 1 month or 21 days, something like that. If the patient keeps on saying something like this, then it's probably safe to assume that he might be having PGI. And now patient of course has pain. So psoriasis because of increased skin contamination, inflammatory arthropathy, and we discussed that yesterday, and demarcating. So wound inflammation, disease, joint form, redness, swelling, sinus, which is cut off normal. These are the physical conditions. So radiologically, you will have signs of loosening. Irregular. It's important to look at the endosteal surface rather than to look at the outside periosteal surface. So irregular scallop border on the endosteal cerebral cortex, periosteal reaction. Of course, if you have a sinus tract and if you did a sinogram, you found that it's transcortical. Obviously, it is a major criteria, and therefore you should diagnose. So, what about serological tests? And these are sometimes the mainstay of your diagnosis. ESR and CRP, good sensitivity but poor specificity. The combination is better predictor for. So, if you are going to get a ESR, always get a CRP. So, don't do them in isolation. Thresholds for ruling out ESR more than 30, CRP less than 10. For prosthetic, for a PGI, which is more than 6 weeks from inside surgery. For less than 6 weeks, if you got a CRP of more than 100, obviously it is infection. The problem comes when most of these patients have a range between 20 and 50. At that point of time, it is unclear with CRP whether it is actually uninfected or infected. So this is a midline, it's a straddling of the. So sensitivity is more than 97% when used together. Other serological markers are actually much more sensitive and also sometimes, and much more specific and also sometimes more sensitive. So WBC sensitivity is only 45%, specificity is 87%. But look at IL-6. Many of us don't have the facility to assay that. But if you've got IL-6 of 10 or picogram or more, then the sensitivity is 97% and the specificity is about 91%. Procalcitonin sensitivity is not too much, but it's very specific. So 98%. So if you get an IL-6 and procalcitonin together, you will find that you can get a fairly good idea of whether this patient is. Aspirations, The indications are very strong clinical suspicion, a high probability of PGI with abnormal ESR and CRP, or even in patients with low probability, but both ESR and CRP are abnormal. And of course, an abnormal plain radiograph, you will not aspirate to done. So, what are what is the threshold for diagnosis here? PGI less than 6 weeks from recent surgery, from index surgery, CRP should be more than 100. Synovial WBC counts more than 10,000 per microliter, and synovial proximal PMNs more than 90%. And if it is more than 6 weeks from index surgery, TSR more than 30, CRP is more than 10, synovial WBC count is more than 3,000 cells per microliter, and 80% of these will be PMNs or neutrophils. You can also do nuclear imaging, and FDG PET is probably the most classical nuclear imaging modality. Increased uptake at bone prosthesis interface is equal to infection, and increased uptake at neck or soft tissue only, that is aseptic. You can do a triple phase 99 precision bone scan, increase uptake in non-tissue. Cultures, 5 prosthetic samples to maximize results. So you need to have at least 5 samples when you're when you are taking them. And culture infecting organ, 2 or more samples is actually gold standard. Both aerobic and anaerobic culture normally kept for 5 to 14 days. And I was just now discussing with on breakfast just today. So most of our microbiologists, what do? After 5 days, they will say culture is sterile, no organism grown. That is the standard report you get for microbiology. Please ask the microbiologist, don't throw away that sample. Keep subculturing after 5 days. And not only subculturing for aerobic organisms, also do it for fungal organisms. So I was trained at Hamburg in endoclinic, where they do a lot of one stage revisions for infected joints. They never threw away their culture. I talked to the microbiologist and said that we don't throw away the culture till 21 days. And if after 14 days nothing is grown, we do it for fungal organisms also, because sometimes you get fungal infections. And with this kind of regime, there's a very complicated this kind of regime. They have 98% success in identifying which organism is actually. Only 2% they say that we are not able to identify. So one of the tenets for one stage replacement actually is know the organism. If you do not know the organism, you shouldn't be doing one stage replacement. So in suspected cases, there will be fungal culture, staph or is the most common for best. Histopathology. So best specimen is periprosthetic interface membrane, and threshold is you've got more than 5 to 10 neutrophils per hyperfield plus at least 5 microscopic fields. This is indicator of it. How do you prevent this? Identify and optimize any modifiers. Risk factors, diabetics, of course, blood sugar control. Smoking cessation should be strongly encouraged. Infections, other body sites should be diagnosed and managed prior to surgery. Is reduction of skin flora helpful in preventing? Yes, it does actually. High quality randomized double-blind placebo-controlled trial. This was the trial. It was published in 2010 in the New England Journal of Medicine. Screening for Staph aureus nasal coloration using PCR, followed by a 5-day protocol twice daily nasal mupirocin ointment and daily chlorhexidine bathing, resulted in nearly 80% reduction in deep surgical site. So perioperative antimicrobial prophylaxis reduces the risk of surgical site infection by more than 80%. Cefazolin is widely used, and dual antimicrobial prophylaxis, cefazolin, vancomycin, MRSA formula. First dose should be given cefazolin, first dose should be given within 60 minutes prior to incision, and vancomycin 60 to 120 minutes. Laminar restaurant body glove suits, horizontal, vertical, horizontal, nobody uses nowadays. Vertical flow pattern, marked decrease in the amount of contaminated air particles in the air, combined with the body glove suit, reduction in the rate of PGI in the first year. And this was a 22-hour paper in the So, antibiotic loaded PMI prosthesis implantation, if you're doing a cemented prosthesis, commercial level product contains 0.5 to 1 gram antimicrobial per 40 grams. Meta-analysis of 6 non-randomized studies found nearly 50% reduction in deep infection among 20,000 primary or aseptic users. Prior to dental procedures, available evidence does not support antimicrobial prophylaxis. And prior to dental, you should do it in prior to dental procedures in case the patient has prosthetic interface. Treatment, of course, I think we will have lectures on treatment very shortly. In fact, depends on infecting organism, condition of patient, and remaining bone stock. And that's the spacer which we normally manufacture on the table. Spacers are very expensive. This is made out of simple threaded Elizaro rod. So two-stage exchange, I think sir will also be talking about exchange, one stage versus two-stage exchange. And this is one patient in which you can actually make an articulated, this is an infected protein replacement, not a hip replacement, but you can make an articulated spacer by hand, and that's the amount of approximately amount of movement you get, about 30 degrees. But once you take them out, you have a fairly good soft tissue as well as bone there. So in single stage, there is are contraindicated. Single stage revisions are contraindicated. There are two previous one stage procedures: infection spreading to a nervous bundle, unclear preoperative bacterial specification, non-availability of appropriate antibiotics, and high antibiotic. I'm not going to talk about operative technique. So the diagnosis and management of PGI requires a special approach. No single test is confirmatory. Determination of PGI is probabilistic in nature, and you have to combine multiple tests to get to a conclusion. Extended cultures are most accurate, and plan for infected revision even in aseptic gluten tests, because the occult infection is very common. Thank you.
Thank you, sir. I request speakers to please stick to the time. We are already running 25 minutes late. Next talk is by Professor C.S. Yadav, Management of Infection and PHR. Each talk is for 10 minutes. Chairperson kindly give the time chair.
Thank you, Dr. John, Dr. Arvind, for inviting me. And I am always happy to be in Bihar. After working 22 years at AIMS, then 2 years at Gangaram Hospital as a chairman, now I am working in the Primus Hospital. That is a high volume center for the joint replacement.
C-type CS is a C-type adapter. Apple. C-type उसमें Apple में भी C-type ये C-type है क्या?
हाँ,
उसमें लूज कनेक्शन इसको लगा दो, इसको लगा दो ना, वो लूज है दिक्कत करे।
Thank you. Most of the things will be covered by Dr. John and covered by Dr. Amit Rastogi. मेरे पास बोलने के लिए ज़्यादा कुछ है because topics may be little bit overlapping. So, as AIMS Arthoplasty course, as we were doing for last 15 years, we introduced cadaver course in the country first in 2008. Similarly, we organize now that National Knee and Hip Joint Replacement Foundation, that is registered body, and cadaveric program, that is our baby, and we love that. We love to train on cadavers our young budding arthroplasty surgeon. So it will be in mid-February. Because I have lab team, so it will be in association some government setup. So we have almost worked over these modalities. So you are invited for that. These things. So infection is the most common cause for the revision, as Dr. Amit told. And these are the classification. I will not go into the detail and because shortage of time. But it is our duty to prevent type 1 or type 2 infection. It is all because of us. So we have to prevent. Type 3 is not because of us. So it is our prime duty to prevent intraoperative contamination. And what I feel most common cause of infection is surgeon and theater setup. Then post conditions are also there, but that is not our hand. We can optimize the patient. These things are in our hand. And that is the most common cause for infection, at least in India, what I've been for last 25 years. So I have seen in the same hospital, same operation theater, same nurse, same implant, few surgeons have more infection rate than the others. So definitely it is surgeon related as well. And even theater setups, a few hospital might be having little more infection unlike other hospital. So we have to take care of that. So overall, in high risk patient, what we have to do? We have to optimize the patient according to their conditions. So that is for the host factor, what we can do. So as I told you, why infection is more in few hands, maybe because they take more time, lack of soft tissue respect, even it is mentioned in the literature, MRSA in nasal cavity. So about the setup, laminar airflow and body exhaust system, it is not necessary. Every year we go Ladakh. This year we went there for 4 days. We did 57 joint replacement, 51 means 6 shift. So overall 276 joint replacement done. Only 2-3 patients had problem of infection, just simple theater setup. And that was the superficial infection that later on cured. So it is the not important, but other things, other things are important. It is mentioned down, theater temperature, discipline, all these things are very important. So what is our practice? It is different, maybe different from people. So I do not use heparin. अगर आप heparin use करोगे तो infection का rate बहुत बढ़ जाता है. I have seen my bosses using heparin and almost in a week, 2-3 cases, they were post-operative. They used to open them, wash them, lavage them. So stop it. Heparin, one of the cause to increase the infection. We have done a study over it. So if you use heparin, all these things mentioned in detail, they are more with the routine heparin use. So we do not use drain for last, I think, 7-8 years. And we stopped using drain because of, we do not use heparin. If we use heparin, hematoma is there. And we use it is a wonderful drug, tranexamic acid. So it stops really discharge post-it is very less. Or if patient lose less blood, so second day patient, they are more energetic, especially in the knee case, bilateral knee में. Blood loss हुआ नहीं, patient is second day, or I am doing CR, we are doing CR. So patient is very alert and energetic. So we do not use drains in any situation except infection and revision arthroplasty. And we usually operate 2000 joints in a year. And infection rate is almost less than 1 as it is the best scenario. So when I was in AIMS, I was taught to give antibiotic for 2 weeks. जब तक काके निकल नहीं जाते antibiotic देते थे. So what I do now, I give antibiotic for 3 to 5 days. I do not believe in the concept of a free of dose laga do. That is Western literature. I still do not believe why. So because so I feel infection in body in most of the situation we give antibiotic 3 to 5 days. So we do not screen our patients, and patient might be harboring infection in some oral cavity somewhere else. So अगर 3 से 5 कोई भी सिचुएशन है एंटीबायोटिक वही दी जाती है, वो दोगे तो there are less chances of infection and immunity of our patients are poor than the Western counterpart. So I give 3 to 5 days, and infection is bad when it is deep, endogenous, when it is deep inside, late infection and with loose processes, and when we are not able to find out the pathogen, then we call it a bad infection. So Javed, Pariviti, they have how to manage the infection. So preoperative strategy, intraoperative, it will be covered by Dr. John and covered by Dr. Amit. And post-operative, my part is just to how to manage infection. Post-operative. So medical, as I told you, pre-operative optimization is most important. Medical optimization according to the disease of the patient. Similarly, अगर कोई patient infection के साथ बाद में आता है, then once again you have to look after the general condition and optimize the patient to control the or to eradicate the infection. So I will not go into how to optimize what you have to achieve. This is mentioned in the literature given these guidelines given by Javed Parviji. So in detail, it is an exhaustive slide. So I will not go into. So overall, you have to correct the condition. If infection is there, to eradicate the infection, that is first step. And about the which demand should be stopped before the surgery, which should be continued. It is also list. It is mentioned each and demand. So what Dr. Amit told, ये बहुत मुश्किल होता है कई बार ये इन्फेक्शन है कहीं पोस्ट ऑप में बहुत कंफ्यूजन होता है डिस्चार्ज आ रहा है आप भी डरे हुए हो पेशेंट भी डरा हुआ है सो हाउ ये डिस्चार्ज बेनाइन है रियली इन्फेक्शन की वजह से वो हमेशा कंफ्यूजन रहता है डिस्चार्ज में भी so simple basically arthroplasty is a mathematics so simple if discharge is coming within in dressing post operative few dressings and it is decreasing with every dressing, it is a very healthy sign. फिर डरने की जरूरत नहीं है. It might be correction. It may happen once in a month in our patient. So it is going down and discharge is not very bad look wise. It means it is not an infection. So if you suspect infection, suppose it is not decreasing down. And even patient local surrounding edema look is not good over surrounding the speech line, then do not hesitate to open the wound, whether it is knee and hip, because first pressure lavage is most effective. अगर आपने जल्दी नहीं किया 3-4 हफ्ते में और discharge 2 weeks तक पहुंच गया, then it is not a good sign. अपना joint नहीं वो दूसरे को दिखाना जाता है. I see lot of patient coming with the discharge to us. So open it, pressure lavage it. In the cases of knee, just take out the insert, clean it from the posterior part, put another insert. So it is most effective and most of the time, अगर primary knee है, आपने किया हुआ है, more than 99% first pressure lavage is more than enough. Now I will put drain in this situation. These are the situations. So it is very rare in a year. So then put a drain and debridements help. If you do debridement, what happens? It dilutes the, suppose infection is there, dilutes the bacterial load. अगर infection नहीं भी है, drain, hematoma वगैरह है, later on it may got infected, you drained out. And when you do any surgery, blood supply increases. When blood supply increases, so antibiotic भी increase concentration बहुत ज़्यादा होगा. So antibiotic concentration also increases because you have done the surgery. It is a surgical trauma, and you can take samples. So do not hesitate to do first pressure lavage. That is most effective. That is the message. And sometimes what happens, as I told you, more than 99% एक ही lavage से काम हो जाता है. If discharge doesn't go, then you do multiple lavages. Even multiple lavage, it is. Don't think एक बार मैंने कर लिया क्या करूं? Go for second lavage, third lavage, and a second lavage almost most of the time, almost near 100 times it reduced down. If it is not a very virulent organism, it is a serious infection. So second lavage may be required. And now उसके बाद भी infection discharge, there are the infection नहीं खत्म हो रहा है. early आपका किया हुआ joint है, then issue of sacrifice of the prosthesis. So it is a very painful, खासकर अपना joint sacrifice करना, it never happens, it happens very rarely. So because this stage the prosthesis is well fixed, so it is what I feel, well fixed prosthesis should not be removed until unless patient is too much symptomatic. Well fixed prosthesis है, patient बहुत symptoms में, then you can sacrifice. केवल discharge है, well fixed prosthesis है, patient ज़्यादा symptomatic, pain discomfort नहीं है, patient is able to walk, so do not remove it. Then after the debridement, put her on long-term antibiotic suppression after the debridement. Not लिख के discharge आ रहा, antibiotic दिए जा रहे हो. To combination of both debridement, lavage and antibiotic suppression. So most of the time, this symptoms basically discharge decreases. Even if it doesn't decreases, continue with the antibiotic until unless patient demands for the removal of the prosthesis and patient is symptomatic. So like here, screw is broken. Iska matlab, it is not a well fixed prosthesis. In this situation, you have to sacrifice the prosthesis. This is late stage. Very easy to diagnose the infection, periosteal reaction, irregular radiolucency, septic, and you can make out on the X-ray whether it is septic loosening, aseptic. There are differences over the radiograph. So in this situation, it has to be taken out. About the antibiotic, we give antibiotic usually third generation cephalosporin and levoflox. That is the what I feel, and we give routinely. It is a very good combination. In the cases of infection, vancomycin is very good. If you want to put organism marina sensitivity ka pata nahi hai, vancomycin is very effective for the empirical therapy as well. This has already covered by Dr. Amit Rastogi, how to treat the long-term infection and how to make out the diagnosis. Dr. Amit covered. So basically diagnosis is made on the clinical judgment से ज़्यादा important कोई judgment नहीं होता. And then laboratory data तो ऐसे ही रहते हैं. I do not. So take your clinical decision and make your diagnosis. These are not infection. Tubercular discharge, clear fluid, and superficial skin necrosis. And sometimes skin necrosis kuch hai. It is not an infection. And positive culture, it may be because of sometimes contamination. So you have to keep these things in mind that these are not infection with septic infection. So like this our case, we operated long back. She came after 6 years. Doctor साहब ये दोबारा से sinus बन गया है. पहले भी इसको TB थी. We did totally arthroplasty. So we put her on ATD once again, second line, and we debrided. So it healed completely within 6 months, and we preserved the joint. And these tubercular joint pain के साथ नहीं आते. जैसे अगर septic infection होता, they used to come with the pain, discomfort, lot of agony. Patient absolutely fine, चल रही है, सब कुछ ठीक है, डॉक्टर साहब बस discharge आ रहा है, वैसे मैं ठीक हूँ. So here in the tubercular discharge sinus strategy is different than the septic infection because there is no biofilm. Another case same because we have done around 100 tubercular hip joints and 3-4 cases I remember we have like that. Put around antibiotic joint preserve and we have published it as well. So it is like a tubercular infection is different from other infections. The principle of debridement will be covered by Dr. John. Dr. John will be covering sacrifice of the processes when it is loose. ETO, when you are doing stage 1, ETO will be covered by Dr. Vikas. So, मेरा तो काम बहुत simple here. These things, these situations are not uncommon after the stage 1. So, what about the antibiotic impregnated cement? I always use in the hip as well as in the knee. I basically Western literature के चक्कर में ज़्यादा नहीं पढ़ना चाहिए. Honestly speaking, we have to see our patient की condition. We have to see our theater setup, our circumstances, and what I say about the literature. My 4C about the literature. 4C literature. 80% literature is useless, irrelevant. Why? It is either controversial, आप मानते हो, मैं नहीं मानता, or copied, और कंप्रोमाइज फार्मा और कंपनी उसको लिखवाती है, डॉक्टर को पहले से एजेंडा बता के रखती है, और चेंजेस विद द टाइम। देसी की आज अच्छा है कल खराब है, सेम हैपेंस विद द इन आवर फील्ड एज वेल, and towering claim about the joint. So use your common sense. So antibiotic impregnated cement, whether it is primary or revision B, so this is all about the managing the infections. Sorry, I might have shoot the time.
Thank you, sir. So our next talk is by Dr. John Mutha, sir, and it is on the two-stage management of infected.
Okay, so I'll talk about two-stage revision, and as we are running quite late, I'm going to be brief. I think this is really going to be a major problem. It already is and will continue to be and will increase in frequency over time, because as you have more joint replacements, then you're going to have more infections and you will end up with more revisions. And by and large, two-stage revisions appear to have better results with less chances of failure. And there are a limited indication for one-stage revision, especially in our setup and in private practice, because even if 1 in 5 fail, it's a big problem for the patient. Okay, so this is one of the articles talking about two-stage revision being the gold standard. And continuing to be the gold standard. And the basic principles in a two-stage revision is that the first stage is you need to try and identify the organism. That happens before you need to do aspirations, etc. You remove the prosthesis, and if there's any cement, you need to remove the cement. So there you need to think of an ETO if you need to do that. The debridement is essential. I think this has to be really thorough. You use antibiotic loaded cement spacer. Usually you would give systemic antibiotics for at least 6 weeks, probably up to 3 months, depending on the return of ESR and CRP to normal. Now, whether you give it parenteral, I think earlier people used to talk about 6 weeks of parenteral antibiotics. Today, most people have gone away from that and usually give it for a week to 10 days and then turn to oral antibiotics. Before you do your second stage, you must give them an antibiotic-free period to make sure that your infection is adequately subsiding. Debridement, as I mentioned, is the key. I think this needs to be thorough. Remember, before you do your first stage, stop the antibiotics. A lot of patients will come, they're already on antibiotics. You need to stop that because whatever cultures you want to get from your deep tissue, etc., will not be there if they're already on antibiotics. So make sure they are off antibiotics for at least 10 days before your surgery. As I mentioned, this debridement has to really be quite radical, meticulous. You need to excise any infected or non-viable tissue. You need to ream the canal. And also the acetabulum. People tend to neglect the acetabulum because you're worried about bleeding, etc. You need to really clean out everything in the acetabulum before you put in your cement spacer. The second stage is after resolution of clinical and inflammatory signs of infection. In our setup, that's usually around 3 months down the line. You need to remove the cement spacer, do a revision debridement. So clean out any membrane, etc., that may be there. If there's obvious pus, then you have to repeat your debridement. So if you go in there and you find pus, then you do not do your second stage, you need to revise your debridement. And then do your revision total hip replacement. Now, there are various cement spacers available. Some are commercial, some you can make on the table. You have these nice molds. Unfortunately, we do not have access to these, so we make do with some kind of innovative techniques like this, or we even just put in a cement spacer, although this makes the second stage a little more difficult. A couple of examples, a few examples. This is a 76-year-old gentleman who had a total neck hip replacement after a fracture neck femur elsewhere, came to us about 6 months down the line with obvious infection, discharging sinuses. You can see the sinogram there. That was the first stage. You took out everything, debrided adequately, and put in your cement spacer. And then once things had settled down, you go in and do your total hip replacement. Now, we would, in a lot of situations, use sort of cemented replacements in the second stage. This patient, we used a dual mobility cup with a cemented cup, and that is him when he came back about 7 months later with a neck femur fracture. You can see that hip is still doing well. We had to do a bipolar for the opposite side. Here's a younger patient. This was his original injury, and the surgeon did a total hip replacement. He came, so we have serial X-rays. I'm not going to show all of them, but came to us about 1 year, 3 months down the line. You can see the huge amount of subsidence there. In this case, we did an ultrasound and then aspirated and grew cultures. Then decided that we need to revise this. And again, we did a 2-stage revision. That was him. You can see the amount of shortening he had because of the subsidence. And he's walking with a limp and with support. He's not unable to walk without support. So we went in again, did a 2-stage revision. The first stage was a thorough debridement with the cement spacer. And then that's him at about 3 months down the line. And we went in and did a revision here again. So here we did a hybrid total hip replacement with a cemented stem. I think we like the Exeter stem, which works well. You use the appropriate antibiotics in the cement. You usually add vancomycin to the cement if you haven't got cultures. If you have cultures, we try to put appropriate antibiotics in the cement as long as it's a heat stable antibiotic. This last piece, this is a young lady, and we don't have her old X-rays before this particular X-ray. I think she had a ipsilateral neck shaft fracture, which was treated elsewhere, which failed, and then eventually had this long stem total hip replacement and came with infection. You can see that she had discharging sinuses. The sinogram there showing the infection going right down into the cavity, the medullary cavity. And this was a difficult situation because we had this long stem. Luckily, the removal wasn't so difficult. So we went in, did a thorough debridement, put an antibiotic spacer for the hip as well as an antibiotic rod for the femur. So that was the situation. And then once things had healed, we had to decide what to do. So what could you do? Yes, this is an infected hip and with a sharp fracture. And this is what's happened, and we've got the infection control now.
Infection control.
Infection is now controlled, and we'll come to the revision. What would you do?
I think probably Wagner, long Wagner.
So you go for a long stem.
Long stem. Wagner, they have, I think, 22.
Sure. Yeah, so
it's excellent fitting right now. And cup side is not an issue.
yeah, so the problem was this lady with this hip, which was reasonably well fixed distally.
Another option may be put a short stem, put a plate.
Yeah, so that's what we decided because this fracture.
Short stem, they are short stem, put a plate down.
Yeah, so that's what we decided on because this fracture had not healed for a long time with this long stem. So we decided to treat that as a non-union, and we did a short stem cemented total hip replacement and did a plating and bone grafting for the femur lower down. So that's what we did. This is still early days, so we don't know what the long-term results are. Now, this article discusses where you can do a one-stage procedure. The thing is, if you do a one-stage procedure, it's a lot better for the patient than a two-stage procedure. Okay, and I remember some years ago, there was a debate between Wagner and Weller. Okay, so two big giants, they were debating about one-stage revision or two-stage revision for infected total hip replacements, and Wagner was talking about single-stage revision and Weller was talking about two-stage revision. And at the end of it, Weller came and said, I'm not so brave as you to do a single-stage revision. And Wagner came back and said, it's not bravery, it's economics. Okay, so they work on the fact that economically you save a lot if you can successfully do a single stage revision. And even if 4 out of 5 work, you're only doing a 2-stage in one patient. Okay, so that's their logic, but I think that doesn't work in India in our practices certainly. Okay, so the ones they feel are suitable for a single stage are the ones where the organism is something that you can treat with antibiotics. So it's a sensitive organism, and you know that you do not have to put in bone grafts or augments. So those are the ones they would consider for a single stage revision. The others would be obviously more appropriate for a 2-stage revision. So I think what is important is all of us should understand that this is a problem which will continue to grow. There are multiple problems involved in the management. Some of them will need allograft or bone graft substitutes, and you need to have adequate access for a bone bank for that, which we don't have. The risks of complications are high, so recurrence of infection is going to be high in this. If your normal infection is 1%, it's going to be 3 to 4% for your revision for infected total replacements. Isolating the organism is important because if you're able to do that, it's much better in terms of what antibiotics you can give these patients. Unfortunately, we do not have 98% success rates in our cultures. It's closer to 40 to 50%. So that's a problem. And as I said, 2-stage revision is still the gold standard for most of our patients. Thank you.
Thank you, sir, for your excellent presentation on this complex topic, and you have finished well on time. And you have made this complex topic simpler for us. And now our next speaker is Dr. Ratnesh Singh. Please come.
So good morning all. Presenting case of infected THR. Mr. 35-year male came to us in March 2019 with a chief complaint of pain left going for the last 3 months and discharging sinus for the last 1 month. There was history of bilateral THR done 1 year back at other hospital. This is the X-ray available 1 year back. It is of July 2018, post-operative period for the primary surgery. Now the patient came to us in March 2019. This was the X-ray. There isn't much change in the X-ray except the very thin line at the cup. But since patient present with a discharging sinus, the sinogram was done and it was coming from the joint. So we decided for the debridement and removal of the implant, which was done as a stage 1 procedure in April 2019. Uncemented implant was removed and the cement special was applied. Patient was given an antibiotic for 6 weeks and there was 2 weeks antibiotic holiday period. After that, the second stage revision was done in 2019, June 2019, approximately 2.5 months after, when all the signs of inflammation and infections has settled. And this is the immediate post-op period. This is the X-ray almost 2-year follow-up. Patient is doing well. This is the clinical sign. Clinical picture. Patient can stand on both of his limbs easily and can walk comfortably. So again, the question is single stage versus 2-stage in these kind of situations. And antibiotic duration. How long you prefer to give antibiotics? 6 weeks, 12 weeks, 8 weeks?
Rastogi, sir. So you're doing a 2-stage revision, right?
Yes.
Okay, fine. It's okay. I normally keep these patients in the hospital for about 10 days and I give parenteral antibiotics. And if it is possible, then I give parenteral antibiotics for 2 weeks after putting the pills in, which is already loaded with an organism specific antibiotic. So after that, I send these patients home on oral antibiotics for 4 weeks. So 6 weeks have passed in total with antibiotics on. At that point of time, I will get a GSR and a CRP and if possible analysis. And then after 14 days, I'll stop all antibiotics at that time. After 14 days, I'll repeat all these tests again. And then if everything is okay, then I'll do a.
What about antibiotic holidays for you? 2 weeks, 4 weeks?
That's what I'm saying. 6 weeks, I will stop antibiotics.
And wait for 2 weeks.
And wait for 2 weeks. And at that time, repeat all these tests again.
Yes, sir.
So if at the end of the antibiotic holiday, you find that the virus is creeping up, your ESR and CRP are creeping up, and it's not settled, then you do a repeat first stage.
So, what is your antibiotic duration in second stage post-op?
No. You have done second stage in the anticipation that now there is no infection. So you will treat for the antibiotic. So I usually do a cemented for these patients. Whatever antibiotic is there in the cement is fine. I will give a 3-day, 3-day antibiotic, IV antibiotic, just like we give for every intermediate replacement. And I leave that.
Because how long antibiotic?
I would repeat the antibiotics for 6 weeks over, I mean, parental while in hospital and then 6 weeks. Total even older because I'm worried about the recrudescence of infection, however much your markers are okay. When you're doing a second surgery in a situation that has already been infected before, I would still be on the safer side and continue as frequent antibiotics. You see it?
Sir, after
As
14 days,
Dr. John said.
14 day implants.
I agree with you on something, whatever. Said I'm glad we agree on something. Yeah.
I would like to ask, what is the role of antibiotic loaded stimulant beads, especially in the second stage where while you're progressing? In the first stage, do you prefer to give stimulant beads with the requisite antibiotics?
मैंने और कभी एक बार यूज किया था पर उसके बाद मुझे ज्यादा कुछ लगा नहीं।
Otherwise, sometimes in the intramedullary cavity, we give beads made up of cement beads, antibiotic loaded cement beads in the intramedullary cavity, because that is also to be cleared.
So the only problem with stimulant is sometimes you get discharge for a long time. And it's very difficult to make out whether this is actually just discharge of the stimulant which is degenerating and becoming a fluid, or it is actually infection. And so I avoid it in these cases. I do use it for some of our infected non-humans, etc., but not in total hip replacement.
Giving stimulant in the intramedullary cavity, I think.
But yeah, it doesn't, it's less actually because it's
Superficial.
Yeah.
Essentially.
true, but then we put in antibiotic cement into the canal and
Especially the only point in giving stimulant is when you are not planning to take it.
Yeah, so in second surgery.
If you are going to do a second stage, you might as well put cement in because it's going to take it out anyway. So might do that.
After doing the revision surgery, once the implant is inside, after that you are giving antibiotic for 3 days, just like
I am usually doing a cemented, so for next 3 to 4 weeks, the antibiotic is leaching out of the cement anyway.
And sir, your protocol is to give
Normally,
it
what,
after putting the implant.
yeah, but what sir has said, if I am doing an uncemented revision, then I would give antibiotics for 3 weeks. But if I am doing a cemented revision, I have got antibiotic in the cement, then I am not doing it.
But some literature says or some surgeons say they give for long life.
Antibiotic suppression, I don't think is a good idea.
Not
It's just
more than 6 weeks.
Yeah, it's just finding yourself, you're an ostrich and you're putting your head in sand.
उसको कहो तू खा के देख लाइफ लो।
I think antibiotic suppression has
तो दिमाग खराब हो जाता है आदमी
I think antibiotic suppression therapy in the true sense where you give long-term antibiotics is for those situations where you have a well-fixed prosthesis in a poor surgical candidate. Okay, and you don't want to go through major surgery. There you are is a situation in a type C host where you would continue with antibiotics for a long term. I think just as a suppressive thing. The other is the use of rifampicin.
Charge is decreasing. And I give 5 days antibiotic. In these situation, probably I may increase 5 more days. Or if the discharge is continuing even after 10-12 days, I will open. I will just pressure Nawazi for ठीक हो जाएगा. Honestly speaking. And close it now. I will put it in simple.
But the other question to you.
I will stop aspirin or whatever we are using that.
The question is, if the CRP and ESR, they are equivocal and you cannot make a decision, what is the role of most of this like interleukin 6 or procalcitonin?
वो सब यार आते जाते रहते हैं हिंदुस्तान में तो वैसे भी मैंने बोला आई बिलीव इन क्लिनिकल जजमेंट ये फार्मा डिबेट ऑनेस्टली स्पीकिंग वहाँ यूएस में भी इसके ऊपर डिबेट है कि अब कभी इसका ट्रेंड ऐसे जाता है फिर ऐसे आता है तो ये अपना क्लिनिकल जजमेंट अपने पेशेंट के फ्रेंड बन के रखो ये गौरव फार्मा फ्रेंड ड्रिवन वाला चीज है
I think single ESR and CRP has no value, not much importance. Just get it done serially if you are believing that infection is.
Corroboration of the finding.
And the last, I just want to show you the sample technique, which is very important. While you are taking the 6 samples with the same sample and same instrument, there is high chances of cross contamination. So it is a better idea to use different container, different instrument for all your 5-6 samples.
So one more thing, how many of you have got a positive benefit by using rifampicin? Quite often.
I'm not talking so much in total hip replacements, but
Rifampicin not as antitubercular.
No, so certainly in some of the implant related antibiotics, not necessarily total hips, where we've been able to get rid of infections in, and never give rifampicin on its own. You have to combine it with one of the ofloxacins or another antibiotic.
Becomes antitubercular.
No, it's not antitubercular.
My question is, rifampicin has been, it has been acclaimed to be it has come in books in long back. I put a question. The only tool we have is the rifampicin, and at the background of implant related tuberculosis, even if you get good results by using 2 anti-tubercular agents, ofloxacin, rifampicin, then probably it remains a doubt whether it was a biotic infection or a tubercular.
How does it
That's the example.
So,
Because tuberculous or not, you can't prove or disprove.
Not at the manufacturing complaint, but with the 2 weeks they come for future report. We'll ask them if there is any problem or not. And then they come subsequently every 3 months for the first year. In the first year is the critical time for you. So if the patient starts complaining, he says, I was walking fine. Now suddenly I have pain. That's the time I start. If the patient says I have got nothing, no problem.
And in early post-operative period, like after 3 days, patient starts complaining of pain without any sign of inflammation and nothing. Simply movement and rotation of the joint leads to pain. Do you suspect infection in those cases?
See, you have just operated 3 days back. Obviously, the patient is going to have some amount of pain. The thing is that every day, that pain should keep on increasing. If it's increasing all the time, if the patient, and then at the same time, then you will have laboratory confirmation of your infection. If the skin is becoming better.
I think post-operative pain, which is out of proportion. And examples where everything. Deep infection or something of that sort. If they're having pain, I mean, of course they'll have post-operative pain, but that should be going down gradually. If third, fourth day that pain increases, always take it seriously.
After third day, the pain persists.
What is the point? The patient is with you for at least 5 days, 5 days after the surgery. You find that the patient is actually having more problems at the end of the 5 days than he had before. That is the time when you get very scared actually. So that is the time. And this is also the time when you intervene properly. You will get implant retention as well as resolution of the infection.
So it was a very lively session, and I'm sure given time it will go on and on and on. So with this,
Yeah, sure. So we'll close the session now. Thank you, Chairperson. Thank you, all the speakers. We'll do the felicitation later on. And we now move to the case discussion. Dr. Risha will be taking. Thank you.
Good morning to all. Now we'll start with the next session, that is our case discussion. Now invite as a chairperson Dr. John Mutha sir to come on the dais. And Dr. C.S. Yadav, sir, Dr. Vikas Kapoor sir, and Dr. Sanjeer Patna. Kindly be there.
डायरेक्ट हो गया डायरेक्ट पहले 1 में लगाए थे तो दो वाला ये शो कर रहा था उसमें तो 2 लेवल उठना दोनों में अलग अलग वे से
A very good morning to all the delegates here. So I'll be presenting case of total arthroplasty acetabular fractures. So as we know, THR in acetabular fractures with the increasing incidence of high velocity trauma, pelvic and acetabular fracture have increased substantially. Acetabular fractures have multiple complications, most common being the secondary osteoarthritis of hip in malunion or non-union of acetabular, leading to the total hip arthroplasty. So there is also increased incidence of AVN of. So this is my case for case. So he is a male, 48 years of age, sustained road traffic accident 1 year back, leading to injuries around the left hip. The past histories or no other comorbidities. The treatment history, he was
treated at a local hospital with skeletal traction for the fracture over the left lower limb. He was kept on the skeletal traction for 2 months, after which he was ambulated with crutches. He visited our OPD after 1 year of injury. On examination, we found that the overlying skin was normal, range of motion was globally restricted. He was unable to squat and sit cross-legged, and there was around 4 to 5 centimeters of shortening, and there was no neurovascular deficit. So this is the immediate post-injury X-ray, almost 1 year back when he visited us. So you can see he sustained a acetabular fracture involving the wall with a dislocation of the femoral head. So this is the X-ray 3 months after of injury. So he was on skeletal traction during this period, and after this stage he was allowed to walk on crutches with partial weight bearing. And this is the X-ray when he visited us around 1 year after injury. So you can see the fracture has healed, but there is a region of the femoral head with lot of bone chips. You can see lying here and there of the wall, and there is a little amount of protrusion also present. So what next? How you plan? So this is the CT scan of the for the planning purpose. We all in all cases we do the CT scans. This is the video. I'll skip running it because it is very evident what are the pathologies there. So my approach to the case, I always work hard to classify my fracture and what are the defects and anticipate what we are going to see intraoperatively. So according to the AOS classification, it is of type 2 gross classification, type 2. I'm sure our next speakers will be talking on classification on acetabular fractures. So my surgical planning, pre-anesthetic workup and assessment of the blood loss during the surgery, surgical approach. I prefer posterior approach, and in this complex cases, I think that is the approach one should do. Blood loss assessment, bone loss assessment. So bone graft, metallic augments to be ready in my armamentarium, and internal fixation of the acetabulum in case of non-union if found during weaving and during intraoperatively. Selection of implant, cemented or uncemented, and what should be my post-op protocol. So these were the things in my mind. So this is the intra picture. You can see I have tried to show you with a pointer that this is the piece of acetabulum which has got stuck to the neck of femur, and this is the acetabulum. When we exposed, it was a big cavity there, but well contained. In my surprise, we found that a lot of both the columns were intact and the traction has worked in a good way. So this is my post-op X-ray. We did a uncemented total hip arthroplasty, and this is 3 months post-op. The patient is happy and walking. So I straight away go to my second case. Yes.
So first thing, why did you call it ABN?
So the femoral head is
it's an arthritic joint.
Yeah, it's a secondary osteoarthritis with
incongruent reduction and able to get an arthritic joint. ABN will present differently, okay? Where the head only is injured, is damaged, and at 1 year the joint will still be pretty okay. Yeah, so first thing is that. The second thing was what were your options that you had when you were doing the rolling? Because this is otherwise a reasonably
problem. The movement was grossly restricted, and there was shortening. There was it was a painful thing. So the options which I had in my mind that we due to the financial constraint of the patient, we did have the metallic augments for him, but I took the option of putting a structural grafts if we found deficiency in the acetabulum, as the CT scan is showing. There is bone loss in the posterior wall.
So,
And combination supro.
I think if you look at the CT, it's a reasonably contained. And you have the head.
Yes.
So you can use the head for impaction grafting.
That was in the plan that we will be using the head.
I think this was a situation where you probably would not need augments inside.
I think we have not given screws in the car.
No, it was not. Yeah, it was a very nice fitting cup, so we didn't.
If you see the post-operative X-ray, were you a bit concerned about the extra bone that is?
No, that was not from the classification. It was the pieces of the old fracture which was lying there.
See the post-operative X-ray.
Yeah, it was not impinging in the movements. So I didn't want to do more of
some issues.
Yes, and increase that.
Yeah. Could it cause a secondary impingement?
No, it was not.
What was the size of cup?
Sir, it is 52.
Just 50.
Yeah, it's 52 cup we have applied with 36 head.
So this is immediate post-op. You don't have a follow-up on this.
No, sir, we don't have a follow, but 3 months I arranged a video. So immediately I go to my second case, 22-year-old female. There a history of fall from the second floor leading to the pelvic injury with SI joint disruption. She had a sternum fracture, both column. She was operated elsewhere. So there was around 2 centimeters of shortening. This is the post-op X-ray. Not post-op. This was post-fixation X-ray when she visited our OPD. Lot of implants been put there, screw with a posterior plate and SI joint screw. Again, she was having lot of pain with an antalgic gait and restricted movement around that hip joint. So again, I did try to classify my acetabular problem, which is type 2 and cross classification type 1. So my surgical planning was again about the bone loss assessment, surgical approach, removal of hardware from the acetabulum. I feel we should remove the hardware which is causing problem and left what is not causing the problem. So the selection of the implant, cemented or uncemented, and the post-op protocol. So this is in this case, we found lot of irregularities in the acetabulum. There was some, it was not a congruent joint obviously, but it was well contained and we had the wall and columns.
So did you have any intra-articular?
Yes. We had that screw which is showing from posterior to anterior that was lying.
You did a CT before surgery.
Yeah, we did the CT, but I didn't have the CT.
So I think this is why you need to
get a CT. Yes.
Yes.
We removed that screw only. I will show you. So this is the post-op X-ray. We didn't remove the plate because that was not coming in our way. So we left that, and the SI joint screw is also left out. So this is the AP and this is the lateral view. No, it was not required. And personally, I don't practice a lot of impaction bone grafting because there are a lot of papers suggesting that it leads to early loosening because of the absorption of the impacted bone graft. Whenever I need a bone graft, I use more of the structural allografts or bone grafts to fix it.
In this situation, sometimes that metal plate was visible in some when you were reading.
I was there. If it was visible, I will put some morcellized graft there, but it was not. It didn't.
So your statement is true when you are doing massive grafting. Not in this situation. It is very useful, and you should always keep ready morcellized graft. In this situation, may be required because you are not doing massive. And what we have that metal cutting, or we can push from the that plate to inside like that, then put a graft over there. So metal cutting bird should always be ready.
If we are putting some morcellized graft, it's better to give 1 or 2 screws for initial fixation. And then if you are concerned about
what I believe that if you are getting a good press fit, the screw, and generally if there is a acetabular fracture, your acetabulum is very sclerotic. And if you leave it nicely, and if you don't have a very osteoporotic old age, both cases are relatively young patients. So you get a good press fit. It is important to leave it nicely.
So you get a good press fit in your case. There's screws, one or two screws. We put it and basically it should be put if you don't, if the bone is very osteoporotic. And it is always tough to have broken one of the shaft of the drill in putting a screw in one of my cases of because it becomes so sclerotic and hard bone because of the union and all. Many a times we may not be able to pass it. But in both the cases, I got a very nice press fit, so it was not required.
Okay, in action grafting, they were just trying to localize the stuff.
Yes.
Which is a very useful guiding and
Basically,
so I think it's not something that you just write out saying that it will use.
so, but there are papers which suggest that there is a lot of losing because of
That's why
the
you have to use the massive amount that
that is too extra. I agree, sir. So my key points, pre-operative planning is of utmost importance. Success depends on the intimate contact between the implant and the remaining host bone. Create a stable mechanical construct that minimizes micromotion, promotes bone ingrowth. Distribution of physiological forces mainly on the acetabulum and pelvis. Correct facial orientation to avoid impingement or dislocation. Restoring hip center requires acetabulum component to be placed as close as possible to the collar line and the infromedial part of your component to be placed near the acetabular teardrop. Restore normal hip kinematics as much as possible. Thank you.
Now I invite Dr. Kumar for his next case. And due to time constraint, there's only one case. And also Dr. Ashwin sir, there's only one case.
A very good morning, and at the outset, let me thank the organizers, especially Dr. John Mukhopadhyay sir and Dr. Arvind for giving me this opportunity. Mine is a case presentation, and that's a very common scenario. That's basically a failed osteosynthesis where patient presented for fracture neck, where the patient presented quite late. It was in fact 15 or 16 years down the line, and he had his own issues, and he used to walk along with the support of a stick. He used to have a limb because of shortened limb, and he started developing back limb. So he just wanted to explore the option of whether he can have a equal limb length at the same time a stable hip and a painless hip. So to just recuperate the brief history, the patient was 52-year-old male without any known comorbidities. The fracture neck femur he had sustained some 16 years ago. The details of surgeries he had undergone was known. What I could infer was he was operated multiple times because primary osteosynthesis failed, and finally he was left to his feet. So that's the X-ray with which he presented. I'll just stop in case I'm asked to, otherwise I will continue the slides. So that's the X-ray. As we can see, there is no neck, of course, it's resolved, and there is great overriding of the femur. That's the clinical picture. As you can see, there's a stick which he uses, that's there in the picture for walking. That's his gait. So that was the gait which he had when he presented. So considering the surgical scar, which was there over the lateral aspect of the thigh, centered over greater fender, and as it was operated multiple times, so it had multiple scars, but then it had healed by primary intention, and there was nothing suspicious as to suggest any infection in the past. Regarding the telescopy, which we should try in all these cases to see how much we are able to pull the femur back. So that was absent, and it was like fixed over there. Shortening was approximately 8 centimeters, quite significant shortening. Examination of the spine is must because in such long-standing cases, we do see if there is compulsory scoliosis, kyphosis, or any other pelvic obliquity. Luckily, it was not there. And whatever it was, that was flexible, so it didn't have any rigid deformity. As for routine workup, all the workups were normal, including the total count and differential count, as well as the ESR and CM. So just taking in the case, I mean, there are so many things which are going in mind, like which approach to go for, because already the SCAR suggested that lateral approach was used earlier. And then how to bring down the overriding femur, because it was fixed and it was going to be a real challenge. And how much shortening to accept. And because we all know that unless we shorten the femur, we won't be able to bring the femur back to, we won't be able to release the, after doing the prosthesis and all, we can't reduce unless we shorten the femur. And then there was what was the choice of implant which we wanted to have.
Just a minute. Because at this stage, any role of skeletal traction? Yadav, sir?
Not at all. No. It is old, useless practice.
So for how much time, suppose this was case of 6 months or 1 year, do you prefer skeletal traction in this case? Even not. So how much till how much time do you think your skeletal traction can work in such type of case?
Skeletal traction for what?
For pulling the femur down.
Not at all. Believe that. Not at all. It should be done intraoperatively.
Okay. So all the time it should be a straightforward to the OT. So many surgeons prefer putting a skeletal traction for a very long time, even after so much of time. So this is the message. We should not put a skeletal traction because we are not going to gain anything with a skeletal traction in such type of cases.
The only thing you can just add is stress view X-ray. If you are concerned at how much of
traction
you will stress traction.
That it is going to be the other way. You put in a traction for a very long time, you end up having osteomyelitis in the you have an additional problem once you have done it.
But it's very common practice at this periphery side. People use to put a skeletal traction.
जब ओटी टेबल पे सब कुछ आप रिलीज कर देते हो और तुम्हारे साथ जवान असिस्टेंट है वो उस समय मैक्सिमम पॉसिबल होता है उसी समय होना है ट्रैक्शन से कुछ नहीं होता है इट इज यूजलेस प्रैक्टिस इट शुड नॉट बी डन
So this is the method.
So I decided to go by posterolateral approach because that's how I usually handle my cases. And I was more comfortable and confident that way. So that was a natural choice. Now regarding the overriding femur, I had my plans to do a sequential population release, which included 360 release of capsule to start with. Rectus femoris.
In these cases, osteotomy is not required because it is adult required shortening. So it comes down very easily once you do the release.
So actually, this case it was not coming. That was the last resort. So that was in my mind to go for osteotomy in case of, in spite of all the extensive release, including the SWAS and everything. But how the shortening to expect to accept? That is the thumb rule. Like we should never try to equalize the limb because even if you happen to equalize the limb, which we always aim for other primary cases, the patient has got that apparent feeling of over lengthening of the limb. So that is very important that you take the consent. At the same time, you also keep things in your hindsight that if you have to actually keep the limb slightly sorted. Otherwise, if you equalize the limb, then you will have a patient who is always complaining that they get a feel as if the limb has been over lengthened. So that can become a litigation cost. So minimal possible, but to ensure not increasing. That's the thumb rule. And the implant wise, I had kept a strong modularity. I mean, because of modularity, again, that can be, I think, debated. The Wagner or something like that would have been used. So I did subtherapeutic osteotomy in this case, and I used a strong. That's the immediate stop. But the story doesn't end, unfortunately, there. Probably we forgot to pass on the instructions of what exactly precaution patient is supposed to take postoperatively. We had failed somewhere down the line. And so yet post-op day, the patient is wanted to offer praise. And he dislocated the hip. So having done a surgery with so much of efforts and with so many things at stake, somebody who is hopeful of getting a equal length of living and normal gait and a pain-free gait after 16 years, if you happen to have that post-op day scenario, then that is quite scary. So as we all do probably, I took the patient for dose reduction, but at the same time, thinking that if things don't work, then I have to be ready to revise everything, depending on what all I need to do. So I tried to go for a close reduction, attempted, failed. So finally, I had to open up and reduce it. So per our findings, I could find that capsule repair, as expected, was totally disrupted. A flake of bone had come out. Gluteus medius attachment was slightly disturbed, but still majority of the abductors were intact. So it was repaired with antibody. The cup liner was found to be stable, so I decided not to disturb that. But I was pretty aware, I was pretty worried about the anti-version of the stem, and whether the stem has further sunk or not. So I was like pretty sure that whatever anti-version I had earlier put in, and after again reducing it, could get a desirable combined anti-version, and the hip was stable by all parameters, as we do with shunt test and combined anti-version and soft tissue density, as we do in all other cases. Okay. So that was the post-reduction X-ray. And that was further follow-up. So that was immediate, like 5 months down the line. So definitely we can see there's a huge difference in the way the patient used to walk earlier and after surgery. So that's after 1 year, the osteotomy site healed way. So another point I would like to stress, like as we had been discussing yesterday, I didn't use any screws, despite of the fact that the patient happened to dislocate it. So let's talk about if we find to have for a very stable cup, then we need not put screws all the time. Although that's an unsegmented, and you do get tempted to put screws. And that's a 4-year follow-up down the line. It's going well. And that's his 2 days before video, which he happened to send out over WhatsApp. So probably take home versus from this case would be, in a previously operated case, we need to rule out infection, although that was a remote possibility after 16 years. But still, we have to be careful, and we need to consider that thing while operating some cases. When we have got multiple scars, then we need to see the majority of the scar, whether we want to incorporate the same scar in our fresh incision, or we want to take that scar tissue out. So expect altered anatomy whenever already multiple time patient is operated, so not expect anatomy to be the same and to be nailed. So you might be struggling to find so many things which you might not be prepared to. At the same time, in such overriding cases, you will find the sciatic nerve very close, and you have to have orientation of, as we do in DDH cases of type 3 and 4. So you have to be really careful while retracting and taking care of the sciatic nerve. Always have a dictum of sending tissue culture, probably that will keep you safe, at the same time that will give you extra peace of mind, and maybe avoid some inhibitions later on if that happens to get infected. And probably shortening of 5 centimeters or more, you have to be prepared for subtrochanteric osteotomy, although you should always try for all the soft tissue releases sequentially. But 5 centimeter or more, probably too much of traction can lead to sciatic nerve palsy. So that could be a misadventure. So subtracheotomy, you need to have a very low threshold, as probably is well in this case. And learn the subtrochanteric osteotomy. That's really something which is can be very handy and needed in many of the cases, as you happen to deal with more complex cases. Like any other person sitting over here would agree, the posterior approach as the concern always is. So you need to always repair your capsule very well, because chances of dislocation otherwise remains quite high. Post-op instructions, no doubt, have to be given well in advance and very clearly. Otherwise, you will have such non-compliant patients, and you will land up such complications of early dislocations in spite of doing a very good surgery. From again, that's a very highly versatile implant with all the permutation combinations working around 3,200 combinations you can have. So that's an implant probably which matches nothing, and that needs a good learning curve. But then if you want to graduate slowly to complex surgeries, then we need to understand and learn well the techniques of the system. So thank you so much for the patient hearing.
The one question is, you did a subtrochanteric osteotomy. Can you just elaborate a few points? How do you did the subtrochanteric osteotomy? How do you level as well as rotation? How do you mark it? Whether you do it with a rasp inside? How do you calculate the amount of osteotomy that you need to do?
So the osteotomy site is usually fixed. That's around 2.5 centimeter below the subtrochanter. So there are so many ways described. Actually, I have done a straightforward, simple way. But then, if you want to increase the stability, step cut would be better, but not done in this case. And regarding how much you cut and how do you decide and how much more you are going to sacrifice. So the proximal part after having release, and once you cut, that's pretty easy that comes and gets engaged in the joint. Then you see after taking a gentle traction, how much overriding is there. And then that's how you decide. But it's always good to go for a conservative minimal cut, because once you have cut more than that, then there's no way you can revisit. And so you have to have a minimal cut. And regarding the rotation, as you are asking, there's so many ways we can mark before cutting using the cautery. Then linea aspera is always there. So these are the ways. But then what is important is that all these markers, along with all these markers, while you're impacting the final implant, then you have to ensure that somebody holds it properly, so that you don't inadvertently land up doing some unwanted rotation.
Yes, that is exactly what I'm asking, because it could lead to a mal reduction, and that could end up in dislocation of the hip joint.
And sometimes it's not a bad idea also to use the cut known as graft, if you feel like as only graft. If you feel that there is some defect still lying over there, because either obliquity of the cut, or maybe after impacting still you are not able to, that's jammed and you are not able to fill that jam. You are not able to approve both the ends of the bone. Thank you, sir.
Now I invite Dr. Ashwini Gaurav for his next one.
Good morning, sir. Today I'll talk about this again, the acetabular and the acetabular race. This is a young patient with an injury that was 1.5 months old. Somehow he was neglected treatment at his own place and presented to us with this extent. There's another lateral view. In both the AP views and the lateral view, the hip looks to be subluxated posteriorly with a acetabular fracture, and the head is most of the head looks okay. Some part is missing in the inferior part. This is the CT scan that I got, the AP view. It shows here intercolumn fracture with which is probably uniting, and a posterior column fracture which is displaced from PA view. Again, the posterior column fracture is clearly displaced with the posterior wall fracture, which is displaced, but it's a single large fragment. And there is posterior dislocation with obvious head fracture. These are lateral views, same findings with the head subtraction view. We can find a large posterior wall fragment with a displaced posterior wall column. Now, in these young patients, I somehow had an opportunity to operate at 1.5 months, 2 months. And my obviously first go will be reconstruction of the posterior column when we find a large fragment. So, this is the quadrilateral plate view. This is the transverse fracture with a large posterior wall fracture. So, I went to the KL approach and I plated these two fragments. The posterior wall was well reduced, the head was contained, but the posterior column couldn't be reduced properly. It was somehow sticky and could not be much manipulated. But the problem what I faced after reduction, since whenever I checked the range of motion, whenever the hip was placed in 90 degree of flexion and mild adduction, even at 90 degree of flexion, the hip subluxated posteriorly, dislocated posteriorly. As we can see in these sagittal sections, coronal sections, the 50% or maybe more of the head is absorbed. So it was non-concentric and unstable at 90 degree of flexion. And at that point, I decided that even after the posterior wall reconstruction and everything, if the patient is not able to sit, then there is no point in continuing with the reconstruction process. So somehow I had the replacement instruments ready. So this is what I did. I just left the posterior wall, which was his original posterior wall very thin and flimsy because it was already 1.5 months old and osteoporotic. So I cut the head and used it as a robust graft in the posterior wall. I used 4.5 fully threaded cortical screws to hold it with the columns. And then I did an uncemmented cup. This is the sciatic nerve. This is the post-op X-ray. I left the posterior column plate as such, just remove the posterior wall part. This is POD1, and this is a 6-month follow-up. The fracture has well united, and the cup looks integrated, and the patient is able to do full weight bearing without any assistance and working comfortably with movement. So my take home message is always be good to these. Thank you.
When did you allow weight bearing to this patient?
Sir, all structural fractures I allow at 2.5 months.
Full weight bearing.
Yes, a full weight bearing.
Any toe touch?
Started assisted weight bearing, and then at gradually I shifted to at 2.5 months. Structural fracture, whether it
So, thank you, panelists, at the end of this session. We add to our Issues with the later on. We have our next interesting session. I would like to invite our panelist, Dr. Amit Rastogi. Dr. HMRI Vikas. Dr. and Dr. Subhash. So I would like to invite Dr. C.S. Yadav for his next lecture.
I am happy Bihar में भी अब आर्थोप्लास्टी में अच्छा काम हो रहा है. They are doing good cases, good. Everybody has shown good cases and with result. That is really happy to know that.
While this is coming in order, can I ask one question to Dr. Yadav? This is from the previous your lecture. As you said, that in cases of infection in the knee joint, you change the insert, take out everything and change the insert. But what in the hip joint? In hip joint, you simply debride it, simply irrigate it, simply wash.
Most of the time, just it is early infection, simply irrigate.
So you don't think it is necessary to dislocate the hip joint and clean the.
In hip, we routinely do not do that. But once you think it is really infection, you are initial week you are in doubt whether it is or not or there. Even culture is negative.
Yes.
So even if you go for inserts removal, then you can take out cleaning posteriorly. That is better situation. But sometimes you take out the insert, you may lose fixation of metallic shell.
Because in some cases,
in the knee it is cement. The strong fixation is there. Uncemented without the screw or with the screw. So sometimes when you try to take out the insert, you may lose metal gum. Then you have to change the whole thing. So in hip it is, I did not do totally. I'm sure it is very virulent infection.
Thank you. Please start.
अमित किसी और को बुला लो इनके पास वो अभी मेरा वाला एडेप्टर काम नहीं कर रहा है so we can go to the second मॉडल बनने वाला है So this plastic, it is really difficult for everybody, especially for the Yadav, we are not able to see that. There is something wrong with the director. You have okay. Yadav sir. Thank you, Amit. Thank you, Sujit. So I once again invite for this caliber course in February. And this is the situation, this is a good situation. And what happens in DDH? They are falling apart. So overall secret of success, restore the both offset. If you restore both offset, you restore the limb length and restore the hip center and do excellent fixation of the component. That is also most important. After offset restore kar diya, hip center restore kar diya, but you need excellent fixation of the cup. Sometimes it is put into screw and all together give a durable hip. So in DDH, each and every step is difficult. So this is the classification. Like dysphagia, low dislocation. It is not difficult to treat. Even at every center, these can be done very easily. High dislocation, like Pro4, difficult to treat everywhere. And now, how to? This is very important photograph. How to find out the acetabulum? So it is basically take out the pelvic height and 20% of that pelvic height. Draw a vertical line from the teardrop, then another vertical line, and match these two lines. So this is the your side for the cup placement. So this is how to where to put the cup. So surgical challenges at TDS they are cup. It is most difficult. Femur is not difficult most of the time until unless it is not coming down to the acetabulum. Then you need trochanteric osteotomy, subtrochanteric osteotomy to break down the hip. And soft tissue, they are mal placed and they are tight, all soft tissue. Exposure is difficult and restoration of hip center because it is migrated and reduction is difficult and restoring the limb line. So every step is difficult. And what about the acetabular problem? So cup is not heavy spherical in these DDS. They are I also would so cup they are oblong and anterior and superior wall they are deficient and there may be osteotomy, prior osteotomy and CT is needed in most of the situations. And femoral problem like trochanter is abridden and more anteversion is there, neck shaft angle is deranged and short neck is there. So problem is there, implant, most of the implant they are from the western countries. They have big neck, especially coral stem. कभी use करने की कोशिश, you may come out with the coral, but sometimes it is in this situation. There are other implant, they have short neck and their neck shaft angle is like 128 degree. In coral, you have 135 degree or 125. Sometimes they give 125, but neck is big. So our neck, especially in DDS, neck is short. Narrow pectoral canal and distortion of all these structures. So all tissue abductor they are weak, flat and contracted, and femoral nerve and profunda femoris are that is very close to the anterior wall. So take care while you are leaving. So most of the time you can come out with the this depend on you cemented or uncemented cup. Gauge-like graft may be required. Cases and mesh, they are mentioned in the literature, but I have not done even a single case of case and mesh in DDH. So sometimes, most of the time, you come out with just medialization and little sometimes because superiorly you get better bone. So the little superior placement of the hip center, it should not be too high. You come out and little grafting, you come out with more than 90% cases. So about the cemented cup, in these situations, most of the time, chote cup. So ask vendor to keep small like 38 cup as well. And PSL cup, it is a barrel program, but frankly speaking, PSL cup is peripheral cell. Primary के rate में इससे wonderful cup you will not get. It has all the advantage because periphery broad होती है. So whenever there is a protugio, whenever you think bone is osteoporotic, and in this situation, PSL cup, even in the revision, bone is very weak. PSL cup is very effective. Heavy timer, heavy, it may sink into the pelvis. Periphery में जाके इतनी बढ़िया sitting लेता है, center में कुछ है नहीं है. So most of the time I prefer PSL cup because medially, when you medialize the cup, hardly any bone is there in the center, in the medial side. So in this situation, I will not use peripheral, that hemispherical cup. I will use peripheral broadened cup. So sometimes really high end cup like from the company trabecular metal, when there is a less coverage, less than 60% coverage, which may be required. And like about the PSL cup, this patient, 22-year-old patient, done in Jaipur. He came to us, we revised right side. Then after 6 months, he came just 3 days back. We have done the left side as well. PSL cup. What happens? PSL cup is broad. So these this plastic the shape is also like PSL cup in DDS. So shape and even floor is big. So use PSL cup. What it be? So excellent exposure is required for the acetabular reconstruction. Achieve rigid fixation and try to restore the hip center. And important steps about the reaming. As I told, these acetabulum are not hemispherical; they are oblong. So ream according to the dimension of anterior posterior column, not from the superior or inferior width. So otherwise you will overream, you will damage the column. So small cups are required. And why? While reaming that tal and ligamentum teres, these may be guide for you while you reaming, and do according to the anterior posterior wall, not because of superior and inferior extension of the column. And in like it is simple low grade type 1 or type 2. Just medialize the cup, you can achieve in most of the time. Another case, just medialization, little higher center. Another case, up to type 1 or type 2, AB type. You can come out by simple primary thing. Sometimes reduction is difficult type. When you hammer it, you may have some calcar crack. So use the extension that's circulated wire. It may be required. And sometime in the uncemented stem, because you cannot have option of thoda sa niche kar do, upar kar do. That you have with the cemented stem. So always, though I am an uncemented man, but I always keep whenever I think reduction will be tight, it will be difficult to bring it down. So keep low offset cemented stem on the table as well. And like in this case, we have used another case. Here you see, offset is not properly stored. Okay. Even then patient is happy, but we do not know about the long-term result. So another case, so I will not go into the detail. Sometime you have to take out the impingement in these situations. Few patients superiorly, they need bone grafting like this over here. Even after medialization, there may be some, so take out the head, make it into fossilized graft. Like now, Pro type 4, huge dislocation, massive dislocation. So in this situation, there are two options. Either put it up at the higher center or bring it down to the native acetabulum side. So bring it down over here. There are two options. Massive extensive release is required. Just leave the abductor, rest everything is released. Then you sometime you may, most of the time you may bring it down, but like here, it has been done. Somewhere else, patient was happy, just came for the second opinion. So and good coverage is there. So you can do like that, but most of the time, like here, we should try to restore the hip center. Here, very high dislocation type 4. So Iranian patient. So we did osteotomy. I have done hardly few osteotomy in my career of 20 years. 6-7 osteotomy. So most of the time you come out with the simple techniques, but in this case we have done the osteotomy. This is after 2 years of follow-up. She sent video from Tehran. Another patient, here we did osteotomy to bring it down. So hard fact about the hardware, our HOD Mohammed Farooq used to say, once you put any implant, at the same time you also put the possibility of complications. So use less implant, that is by philosophy. Now about the fever. For the fever, most of the time, no issue is there. But sometimes extensive release is required when there is a high dislocation. And here, as I told you, neck is short. So use short stem, unlike the coral stem, use Wagner band, use the other company's short stem. Even they have in JJ, they have some short stem like right in Chota aata hai so use keep ready on these use extensively coated stem. And about the osteotomy, you will not see the neck. You have to take a osteotomy through the head. Then on the neck, because that neck is engulfed by the head, and you take out the osteophyte from all around the neck. And once you do the osteotomy, you hardly find any neck in the head. So it is done. And sometimes traumatic osteotomy is required to bring it down, like in this case. So overall, fracture calcar is not uncommon. Sometimes you desperation aap thoda aur maar do, but if these fractures are a stable fracture, you may delay weight bearing depending on the situation. Otherwise, you can start from the second day. So these are all about the DDS. Complication, dislocation is very common because of impingement. Version, because it is a DDH, inclination is also issue. Neurovascular damage is also. Failure of cup in high hip center, uncovered cup, because superior deficient wall is there, poor biomechanics be restored. So overall, cup failure is common, and it is tricky to do things over the cup side. Femoral issue is not very tricky, except really you require trochanteric osteotomy. You should know how to do it. And use small neck stem, that is important, and reduction is difficult. So release except abductor whenever there is a difficulty. Thank you. Thanks.
One question, please.
So many of these DDH are having excessive anti-person, and many a time company don't provide you this road type of thing. So what is your take on that?
Basically, you can adjust on the cup side. So it more, as I told you, hardly I use modular stem like as from. Honestly speaking, we do I think around 200 hips in a year. I hardly more than 200, hardly use as long, or even restoration stem from the spiders. So what thoda bahut hota hai, you can adjust because it is a combined antiburden which matters, not only on the femoral side. So and itna zyada kabhi nahi hota.
And also the cemented stem.
Cemented, you can do that. That is the option. If you have cemented, you want to, so always keep ready cemented stem in this situation. For to bring it down or for these version purpose.
Yeah, it's very easy with the
cemented stem. Yeah. And also you can use. So don't use modular stem for these things. They are costly and unnecessary.
cost reduction.
And one problem with the using cemented stem, once you try to sink it in, the part of the trochanter usually abuts with the pelvis.
As in our one case.
Yeah.
हाँ.
And sometimes
So you have to be in between, you have to take care कितना करना है.
offset change करना
Yeah.
है उसमें.
हाँ.
You do want to change the offsets, make it.
So they have fixed offset, they have small neck, but like in striker, they have 2-3 small stems, cement on cement, they call it a cement on cement stem.
So in order to prevent that secondary impingement, sometimes it is necessary to give a bigger head so that the distance increases.
Yeah.
Also prevent the dislocation.
Sanjeer, I think we are running short of time. Thank you very much, Yadav sir. What we can continue to use is actually something which has got a low angle. So you don't have a high vertical offset, but you'll have a fairly high horizontal offset.
Yes.
And that will prevent.
And the bigger head.
Yeah.
Yeah, actually, we have almost shown 3 or 4 cases in the morning for totally fracture. So there are 3 scenarios when what we come address whenever we speak about totally arthroplasty and external fractures. One case when it has been previously fixed and the patient has developed some form of complication, like it could be post-traumatic arthritis, osteonecrosis, infection, failed fixations, lysis, or some form of complication like infections. There could be one category, the other category that is called as neglected external fractures that has been previously inadequately treated or neglected by the patient, because in the COVID time, I have seen many patients, they were not coming to the hospital because of the fear and lockdown. So that comes in 3 forms, like non-union, malunion, or a combination of non-union, malunion. And the last part that is emerging nowadays, it's called as acute external fractures, particularly elderly population, severe combination of the posterior wall, articular cartilage damage of the femoral head and the sternum. And so these are the 3 categories that falls under totally arthroplasty and external fractures. So if you see, the problem is different for each category. If you see the conservatively treated group, there is a distorted anatomy, the scars, fibrosis, all these are there. Multiple fragments, avascular fragments, arthritis, non-union, bone defects, all these problems are there. But when it is a previously operated, there is external fractures, the problem could be infection, scar, hardware. These are the major problems. Other than that, there could be bone defect as well. And in acute total arthroplasty, the major problem is instability, because the fracture is now that is acute and it has not united to any extent. So there could be acute discontinuity and non-acute. So how we evaluate these patients? Definitely, we all need radiographs, interpost review, and Juliet views. But CT with 3D reconstruction is a must for all external fractures during the when you are planning for total arthroplasty. CT scan is a must. And in rare cases, you may need a CT angiography, particularly when there is a gross propulsive, because, and one case was shown yesterday. So particularly when the fracture is exiting at the sciatic notch, there is a high chances of superior artery injury. In those cases, CT angiography in the pre-operative period is a must. Ultrasound Doppler for DVT and infection, definitely you need to exclude, and you need to see about the abductor function as well. So this is the algorithm that I follow. So all these complications are there in the external fractures. Bone defect, if it is a cavitary bone defect, probably infection bone grafting is the best, and totally arthroplasty. Segmental strut graft, or you can use the augmented PHA. If it is a discontinuity, probably you need anti-propulsive cup, distraction technique, or cup cage construct. And when there is no bone defect, probably standard total arthroplasty will be used. But in infections, it is always 2-stage PHA. And hardware removal, if it is affecting the placement of a screw, probably in that case only you need to remove that. Otherwise, there is no need of removing the hardware. So these are the problems we have already described. But most important part, I think, the lower 2, that is the abductor dysfunctions and the infections. So you need to be sure that the abductor is working properly. Otherwise, you need to such type of implant ready so that you can prevent dislocations. So this is a very good article published by Myanmar. So where to put the screws? If you see, these are the 5 zones where we can put the screws. Anterior, there is pillar, posterior pillar, then the superior gluteal pillar and the sciatic buttress. On the anterior side, the superior pubic ramus area is there, and the inferior the ischium is there. Here, these are the 5 zones where you can put the screws depending on the availability of bone stock.
And that particular bone stock should be attached to your exoskeleton. That should be stable. So how to decide? Because we know that vestibular fracture is a non-linear mallinear. Many times it's a combination of non-linear mallinear. So remember the principle: raise the cup between anteroinferior iliac spine and ischium. And if it is stable, no need to put any bone graft or anything, not to be done. But if it is unstable, probably you need bone graft on the posterior side and plate it. But the implant of choice is definitely uncemented one, because there are many series they show that cemented implant has poor outcome. But some series have shown that in difficult cases, cemented implant has also done well, but with infection grafting. But you should have all the armamentarium ready: cage, bone graft, metal augment, TM augment, buttress. But remember, the ideal implant is most of the time uncemented cup, highly porous cup, multi-hole, and preferably a 12 mobility cup. So this is one of the case 35 and then post-vestibular fracture fixations about 3 years back. So CT scan shows no intraarticular hardware and
दिमाग नहीं है
I don't know. So when there is no intra-articular, no defect, probably you can go for a standard total arthroplasty. So this is 3 years follow-up of that particular patient, being perfectly all right, no lead, no pain. Another patient, 27-year male, previous osteosynthesis for 3 months old neglected vestibular fracture, somewhere done it was. It is malunited. Now it is a posterior wall, posterior column fracture. So you can see that. And what we have done is actually the medial. If you place your cup on the medial side, so remember that this is a medially displaced fracture. And if you place your cup on the medial side, what will happen? It will lead to impingement and lead to dislocations. So, and it can lead to cup protrusion also. So what you need to see is that which component is stable and which component was intact in the pre-vestibular fracture side, that is before the surgery was performed. So here the lateral iliac ring was actually intact. So if you place it there and put your cups and you achieve a better cup stability, probably your outcome will be good. So what to do in such cases? Lateralize your cup, use a highly porous cup, and augment the wall if needed. And this is what we did in this case. And this is about 6 months follow-up. This patient is doing well. He had multiple injuries. He had actually one flat for the intertibial defect and all this and state. Tibia was a big flat. So even now it is almost 3 years follow-up. This patient is doing well. 26-year female bone defect hardware problem. This patient was operated somewhere 3 times. Initially, some interplate was put in the through metasacral. That is the modified strophy. Then the posterior approach was done. Somehow it was not comfortable. The surgeon could not reduce it properly. So he did again osteotomy and did something. So this lady, young lady, was operated twice before. So if you see the CT scan, you can see multiple hardwares that are inside the joint. So what to do in such a difficult scenario? Because this patient has been operated twice. So what we did, we just accepted a little bit high hip center, and you can accept almost 1.45 centimeter high hip center in such difficult scenario. Otherwise, we could have gone for an augment on the superior side and placed a normal hip center also. But we don't want to lengthen the procedure. So that's what it was done. And now the patients are having about 2 years follow-up doing well. So this was a difficult scenario for me. This patient was operated in 2015, and there was post-osteosynthesis, multiple hardware placed through extended iliofemoral approach. There was severe abductor deficiency. You can see that. And this patient was having severe diabetic and autonomic dysfunction. That is mainly our giving spinal anesthesia. The blood pressure was coming down to around 60/40 like that. So it was a challenge for me. I just removed all the hardware in the first attempt, and then we put one uncemented cup. It all dislocated. I'm not going to show the intermediate X-rays because this patient was operated twice by me also, because the surgical time was very less. So I was not finding any time to think something during the time of surgery. What ultimately I did was I put a constant liner and put a highly porous cup in these patients. And this is about 7 years now, because I operated in 2015. 7 years after surgery, doing well. And there was initial shattering of damage. Now he has completely recovered. Another patient that was already discussed, actually, previous osteophysis was done, neglected vestibular fractures, non-Indian malignant. Here, there was a point that when hardware comes and there is a negligible amount, what to do? In such cases, you have 3 options. Either you can go through the other approach and remove it or push it, but that is dangerous again because if you push it and it goes inside the cavity, there is a pelvic cavity that is quite dangerous. And the last one is the body with minimal lateration by putting bone graft. And this is what we did in this case. We put bone graft and we lateralize the cup and use a highly porous cup, and the patient is also fine. 45-year male, failed fixation, there was lysis of the femoral head, normal uncemented cup replacement was done, and the patient did well. 54-year male, here again, the cup which was protrusive. So what we did, we did infection bone grafting and highly porous cup in these patients and remove them. I just don't want to show the video. So the patient is doing well. Underlying bone surface when it is compromised most of the time. So it is sclerotic, it was nicely mentioned in one of the cases. So highly porous total cell and no implant was removed in these patients. So what you do, that was for the previously operated case. Now coming to the neglected case, in these cases, all columns are displaced. You cannot bring it back to the normal anatomical positions. So try to reduce it as anatomical as possible. Fix it with a plate or give stability. Decorticate the inner cortex and put or fill up with bone graft, morphalized bone graft, and then put a uncemented cup. So the same principle that we follow. But here the technical demands are like how to define the version, inclination, soft tissue balancing, limb length, offset, and defect, how to tackle that. We all know that how to do that. I'm not going in detail. So showing some cases by which we can just understand that this was a monumental established fracture in 37-year male, conservative treatment initially, and this is what we did. We put bone graft and put uncemented cup, and this is 3 years follow-up now. This was another patient, 64-year, 3 months old posterior wall fracture. We did the same thing, put the autograft, the femoral in the autograft, buttressed it with a plate, and then this was 3 years follow-up. 64-year male, 4 months old posterior wall fractures. I just wanted to show what I needed to say in this fracture. That you put the trial rimmer, analyze your defect, and then put the bone graft, stabilize it with screws, and without putting the plate, don't try to remove. Whenever you put the screws and just try to remove, you will feel that all your graft that will try shaking and it never unites. So after putting the plate only, just try to remove it. So this is another patient, 9 months old, again did well at 1 year follow-up. Neglected acetabular fracture, 6 months old. This was an ABC type of fracture, so we reconstructed it in the primary letting, and just a few days back he came, he's fine. So this was anterior column defect. We put the emulsionized bone graft and reconstructed it. So coming to the pelvic discontinuity, if it is less than 12 weeks after the acetabular fracture, we say it is acute. More than 12 weeks, we say it is a neglect of the chronic one. In such cases, probably the ideal implant is cup case construct. We all know that. But this case was infected, so we did debridement and lateral structural graft with infection graft. And the last scenario is acute acetabular fractures. So it was a nice study by Taneja in 2012 that which patients do not do good when we do the osteosynthesis, particularly age over 40 years, when there is anterior dislocations, femur head cartilage loss, almost full thickness, posterior wall involvement, and marginal infection of more than 40% is there. And if the initial displacement is more than 2 centimeters. So there is a criteria that is which has happened with me also. This was a patient who came during the COVID time, young patient, 42-year male, ABC. And if you see the CT scan, the posterior wall was totally shattered. It was not existing at all. What I did, I took the IMEC crest graft, reconstructed the posterior wall, fix it nicely through one approach, the posterior approach and the anterior approach. So 2 approaches for use, either femoral and the posterior approach. And what I was expecting is that this patient will do well, but this is what he didn't come for 1 year. And at 1 year follow-up because of the COVID. And when he came to me, everything was dislocated. So what I thought that I just took the patient to the theater. At that time also the COVID lockdown was going on. But this bone was totally fused to the ilium. So on attempt, that is when my assistant was trying to reduce it, protect it. It got broke and we just did the dual mobility of this patient. Yeah. So this group of patients actually need acute acetabular fracture, needs PHR with osteosynthesis that become age more than 40, 60, combination osteopenia, femoral head infections, and dome infections. So there are many options, but I'm just telling about the few basic one. This was a 67-year male, a small fragment posterior wall. So yes, so ignore it and ring medially, and this is what we did. We just put the uncemented cup, medialize the cup. Another patient, acute fracture, posterior wall not reconstructible. We just went to the anterior approach. We put the plate anteriorly and went to the posterior approach and did the posterior wall reconstruction and did the acute feature. So this was elderly patient. So cup case construction is still valid. This was a 72-year male where we did the traumatic protrusive case. This was done. So the future of THR in acute vestibular fracture is going in these directions. Either you can go for 3D printing or a cone process, and you may plan for a cone process next week because we have ordered to the company to bring this cone process for us. So if you see the literature, initial literature was mentioning that the outcomes are bad, but with the current available implants, the outcome is very good in fact. So recent literature suggests a relatively better outcome because of better implants. And impaction grafting does well. I'm not saying that it is bad. Rather, the structural graft did not well. They do not do well. If you see the MEAR series, it has clearly shown that at 11 years of follow-up, 50% of the patients with structural graft, it all resolved. But what we are following our cases, why we are following that? Because now we are using a better implant. So we expect that much of lysis will not be seen in our cases. So this is what we published at that time, and almost 3 or 4 articles were published by us subsequently. But what I realized is that the outcome is not so gloomy as we are publishing in this article. But if you realize, it all depends on the initial management and initial condition of the patients. So take home this is that totally arthroplasty after vestibular fracture is quite challenging. And the key to success is you need a stable fixation, stable socket, and a stable hip. But remember, the highly porous multiple dual mobility curve and TM augments or buttresses have solved most of these problems. Thank you.
We have 2 questions, please.
One question is neglected vestibular fracture, particularly as you are following your head is almost there. So what is your take to take out the head?
Neglected vestibular fracture.
Yeah.
Head is
almost head is in. It's almost 40. Your head is in.
Okay. Actually, just before coming to this conference, we operated a similar case where the head was totally engaged inside, and the ilium, that is your trochanter, was emerging almost towards that is near the ilium. In those cases, go for in situ cut, and then you take the slice with your saw. Whatever head is there inside the case, you take slices, bring it because you want to use that as a graft.
Yeah.
Forget about the remaining pieces, what you cannot do.
So message is always do in situ cut. Don't try to dislocate the hip in neglected type of thing. And if it is overridden, always be prepared for do trochanteric osteotomy. Otherwise, very high chances of heterogenic trochanteric fracture or something like that. Thank you.
What is the minimum post-bone and implant contact you want in a post-vestibular fracture?
Actually, it is 50% as per the literature because we are using all ultra porous cup. But in case of trabecular metal, even 30 or 40% will go well. Because I have just revised the case last week. I have not put that slide because of the time constraint. So we did the first post-vestibular fracture. We did the THR in 2016, and now after 6 years, what we found is that the cup was loose. There was aseptic loose. So now I use your TN cup. So in 30-40% in case of trabecular cup, it is all right. That's the lowest of what I am saying. But it is ideal to have this.
Please.
Okay, good morning, everyone. Thank you, both my speakers and other speakers. So we have been talking about a lot about advanced type of arthritis, advanced type of hip OA that we are dealing with, and these are all experts. We are dealing with these cases. Okay, as a beginner, probably you will be getting simpler cases, but then if you don't evaluate properly, even the simple case become complicated. So probably my talk is not for the first 2 rows and people on the dance. It's probably for those who are sitting behind and starting, or have started, and they are going further. So we need to understand that time has changed completely. Okay, and people are getting more and more surgeries. They are coming to you after one surgery being done somewhere else. You're coming to you for getting the second surgery done. Satisfaction rate of the patient is completely changed. They want best and best and better every day. Okay, so remember this in your mind. And why I'm telling you this, because we have been talking about spine and pelvis. Okay, so all the videos have been taken from YouTube and Leon videos. So Leon videos are very good. If you want to see that, it's really available on YouTube. Okay, so my goal of presentation is to make this concept very simple. I have mostly a theoretical, so stay away. I'll try. This paper was very important. Okay, spinal deformity
and hip dislocation. So there are around 14,000 patients these people evaluated. Okay, so and then there were controls in that which had dislocation of around 1.55%. But those who had spinal fusion, remember, these see this data, okay? These are not my data. 1 to 2 level fusion, 2.96. 3 to 7 level fusion, 4.1%. So it's a quite a high incidence of dislocation when the spine is being fused before you jump onto your hip. So you have to keep that in mind. Okay, you have to keep that in mind, because if the patient has a spine pathology, a spine surgery already done or not done, they will have a high chance of dislocation. No matter how better implant you have put, how nicely you have done, you have to keep certain biomechanics in your mind. All right, keep that in mind. Leibniz safe zone. Okay, so okay, it was very good, but why this death of Leibniz safe zone happened? Because in a large series, people have evaluated the dislocation rates and they have found that all those who have dislocated, 40% of those patients were in the safe zone. Okay, all the patients that are dislocated, they calculated everything, version, inclination, and they found that 40% of those dislocated were in the safe zone. Okay, so there is something else going on other than the safe zone that people need to understand. And there is one paper that anyone, even the young, old, want to read in this paper. It clearly explains stepwise how you are going to evaluate, how you are going to operate your hip, and how you are going to see your spine and pelvis relation. Okay, so it's a link. Okay, spine and pelvis is a link. You cannot just rule out spine and pelvis. Okay, so it's a small video. I'm not going to take you through, but you see that whenever your spine is moving, your pelvic, your sacral slope, and everything changes. Okay, the spine is moving, your pelvis and sacrum is also moving. So the problem is that if the spine has a deformity, it is fixed, your pelvis will also have some sort of problem. You're dealing with arthritis of the pelvis, but your spine is also creating a problem when the patient stands and walks. That is very, very important for you to understand. Okay. 3 things before I jump to pelvis: sacral slope, pelvic tilt, and what is pelvic incidence. All the surgeons need to understand this. Okay. So what is a sacral slope? So you basically drop a line along the upper quarter of the sacrum. You drop a horizontal line along the floor, and that angle gives you a slope of the sacrum. Okay, that's number 1. What is pelvic tilt? There are 2 ways to determine pelvic tilt. I'm taking this one. To take a lateral, both femoral heads overlap. Okay, you draw a center of the femoral head to the center of the sacrum, and again you draw a vertical. This angle gives you a pelvic tilt. Okay, there is another way of measuring pelvic tilt. I'm not going into that. Just keep it simple: sacral slope, pelvic tilt. Okay, pelvic incidence. So draw a line from the center of the femoral head that you have done to the center of the sacrum, and draw a line along the sacrum. That gives you a pelvic incidence. Remember, the pelvic incidence is a combination of the sacral slope and pelvic tilt, and pelvic incidence always remains same. Okay, sacral slope will change from sitting to standing, standing to sitting. Pelvic tilt will change, but the pelvic incidence remains more or less stable. Now, this is about pelvis. What about spine, and how does they all equate to each other? Okay, so what is then you have to see how you calculate lumbar longest. That is very simple. So you draw a line, upper border of L1, lower border of L5. Of course, some book will say lower border of S1 as well. And then you find out your lumbar lordosis. How these two equate? These two equate is that they all, lumbar lordosis and pelvic incidence, they are within 10 degrees of each other. Okay. If they are within 10 degrees of each other, your spine and pelvis are in a more or less balanced relation. When they are out of that 10 degrees relation, that is where you need to be very, very careful. That is where this X-ray comes into picture. Okay. So this patient on the left side, lumbar lordosis is coming 39, pelvic incidence is coming 36, within 10 degrees, very much equal. On the extreme right of your screen is lumbar lordosis coming 28 and pelvic incidence 50 degrees. They are way off. So now you have to be worried that what you will do in your surgery when you are doing an osteoarthritic hip or a total hip replacement, that you will not cause a problem. Okay. And now let's go to hip now. All enough about sacral slope, pelvic tilt and pelvic incidence. Only these three values. Okay, I'm trying to simplify as much as possible. So what is acetabular anteversion? So there are three types: anatomical anteversion, which is seen in a transverse plane; radiographic anteversion, which is seen in a coronal plane; and then operative anteversion, which you see and in which you operate, which is in a sagittal plane. Okay, so it's quite confusing. Three different planes. How you're going to manage? Okay, so this is what you see in your Excels. Okay, but then this is not what you see in your patient when you operate it. Okay, so you have to be a bit smart about pelvic acetabular anteversion. Let's see this video. So whenever pelvis is tilting, you see that the inclination is changing and your cup is getting opened up. So when you see how it is moving, and your cup, if you focus on the cup, you'll see that it is changing. The cup is changing when you're sitting, your cup version is opening up and its acetabular anteversion is increasing. This is standing, and when you're sitting up, everything changes. Okay, I'll explain more. So what happens when you're sitting? When you're standing is on the left side, when you're sitting is on the right side. You see your acetabular anteversion here. Okay, it is reduced. When you're sitting, when everything is normal, it opens up. To accommodate, you're sitting, your femur comes up. Your femur comes up, your acetabular version has to change, your inclination has to change. That is how it is. It is a 3D structure, it's not 2D. Okay, it changes so that you can sit properly. And at the same time, your native hip does not dislocate. You do, okay, so your native hip does not dislocate, but you see your sacral slope, it decreases, your pelvic tilt, it increases. This is in a normal patient when you stand to sit. Okay, what happens? What happens is that basically when your pelvis is standing, it is anteverted. So when pelvis is anteverted, your acetabulum is retroverted. But when you sit, what happens? Your pelvis becomes retroverted and your acetabulum becomes anteversion. So they act opposite to each other. When you're standing, your pelvis is anteverted. Okay? And your acetabulum is retroverted. But when you sit, your pelvis goes back. It has to go back. Okay? When it goes back, your acetabulum comes forward. So this is basic. Pelvis is anteverted, acetabulum is retroverted. When pelvis is retroverted, your acetabulum is anteverted. Second thing. So first was sacral slope, pelvic incidence, lumbar lordosis. Second is acetabulum and pelvis anteversion and retroversion. They are just opposite to each other. Right. Now only last 3-4 minutes left. Okay? I'm not going to detail. Any change in acetabular anteversion, so safe zone, all these things, they are theoretical. That's okay. We are not going. 1 degree change in pelvic tilt changes around 0.8 degree change in acetabular anteversion. And most often you're not going to calculate this because these are very meticulous calculations. Theoretically, it is very good to hear, but you are not going to calculate. Okay, practically speaking, none of the surgeons calculate. I don't know anybody sitting in front also calculates or not. But remember, if there is a change in too much change in the pelvic tilt, there will be change in acetabular anteversion. And if pelvic tilt is not changing, that is where the lateral X-ray in standing and sitting comes into picture. Pelvic tilt, if it is not changing, the acetabular anteversion is not changing as well. Remember that. That's the only message from this slide. With the change in pelvic tilt, your version will change, but if the pelvic tilt is not changing, why it is not changing, I will tell you now. And your version is not changing. Very important. Okay. Just for last part of the video, actually. So, just a diagrammatic representation how the pelvis moves and your acetabulum changes. Just keeping things into perspective, a 3D model. Okay, so this is the normal what is happening. Acetabulum is changing. Nothing new in this video. Okay, but then it is a 3D structure. It rotates. It changes. Your pelvis is tilting. Your acetabulum is tilting. Okay, right. So we'll go ahead. 2 X-rays are very, very important. So remember, you start doing it now. Probably you'll do it when you're doing it 3-4 PHRs in a week. Probably will be more useful for you if you begin right now getting a standing and sitting spine X-ray. So 4 scenarios. Spine is flexible, it is balanced. Very good. Normal patient. Your spine is rigid, but it is balanced. I'll tell you why. Spine is flexible and balanced, spine is rigid and balanced. I'll take you one by one. Your spine is flexible and balanced. That's a normal scenario. That's normal osteoarthritis. And your acetabulum version increases when you're sitting.
And in this, you do around 5 to 25 degrees of antiversion, and you are in the limbic safe zone theoretically, nothing will happen to the patient. Okay. Now, what is rigid and balanced spine? Surgery has been done, lumbar lordosis is there, but it is fixed. Okay? It is rigid, though it is balanced. But you see that when patient is sitting here, this is standing, this is sitting, the acetabular antiversion, which is supposed to increase, is not changing. So what will happen? What will happen is that when patient sits from standing, it will impinge anteriorly. It will impinge anteriorly and will pop up. It will pop out posteriorly. So you need to increase your version more. While operating, whether you operate in a supine position, whether you operate in a lateral position, Harding's, whatever, increase your antiversion. These are the patients tend to dislocate posteriorly. 2 movements, 3 to 4 movements. Okay. Now, flat back patients, Parkinsonism, they have not undergone surgery. There is no lumbar lordosis, but there is hardly any pelvic movement, flat back syndrome, flexible but unbalanced spine. These are the patients. What happens is that acetabulum is rigid. Okay, so what happens? Sorry, like rigid unbalanced spine. So this was an example of flexible unbalanced, the same one. Okay, so here what happens? What will happen here in this scenario? In this scenario, patient will dislocate while standing up from the sitting position. Okay, and they will dislocate anteriorly because your anterior cup is being opened. And when you're sitting, when you're lying down, these patients sometimes dislocate when you're lying down. When the leg is straight. So these are the patients where the flat back type of patients where you need to decrease your antiversion so that anterior dislocation does not happen. So 2 scenarios when it is fixed in lumbar lordosis, spine is fixed. Second scenario when the spine is not fixed but it's a flat back, and you need to decrease. So you keep it in more retroversion or keep it neutral. Normally, a posterior surgeon will increase the antiversion with a chance of posterior dislocations if here every time. These are the scenarios where you will keep it down, keep it low. Okay, so 2 scenarios. Third one is a very complicated, rigid and balanced spine. This is where probably you'll want your spine surgeons to intervene. Probably you will do, so there are indications that you change your version when the surgery is done. But here also, you don't tend to decrease. So decrease your version, keep it trying, keep it more and more neutral, 5 to 15 degrees only. So nothing much. Only 3 things that I wanted to emphasize is that see your spine. See how the version is changing. Keep that in mind. If you start thinking from today, probably you will be more learned than me. What I am today, 10 years down the line, I'm slowly learning. But probably at your age, probably all this X-rays and you have seen from all the experts, probably you are more going out knowledgeable. But from my talk, only 2 things: spine and acetabular version. Thank you. Thank you.
For the excellent lecture. I think your main message is in one word is that you must examine the spine as well.
Yeah, all the time you need to get an X-ray.
Your question is, he has elaborated very extensively. And the next speaker is Dr. Sanjeer Patna, why THR dislocated and how to manage.
Change karo. Yeah, next time.
Respected chairpersons, my dear friends, some of my talk is now covered by Dr. Sujit excellently, and that makes my job slightly easier. Now, why THRs dislocate and how I manage it? That's my topic. Now, we all know that total hip replacement has been covered yesterday also. It is described as the operation of the century in the Lancet paper 2007. It has revolutionized management of elderly patients crippled with arthritis with very good long-term results. But when the patient is a young patient, that's the challenge.
physically demanding patient, to restore the quality of life, that is the challenge which is going to come in the next decade or so. Better biomaterials and designs with highly cross-linked polyethylene that has made the job easier. Larger heads have come to the picture, so with increased range of movement and increased stability, and minimally invasive techniques with accelerated discharge and rehab and computerized and robotic surgeries coming into the picture for the accurate placement of components. So that has revolutionized. This is the coming decade. That's the future which is going to go in that direction. Short-term objectives must not compromise the long-term performance of the hip replacement. And further developments will be dictated by cost effectiveness. So that is what I want to bring to the notice. Now, we all know we have to restore the hip joint kinematics after a total hip replacement. Now, reconstruction of the cup inclination, abduction angle of paramount importance, proper anteversion of the cup, anteversion of the stem, restoration of the hip center offset, and ultimately restoration of the limb length. All these will lead to a good total hip replacement with good longevity. Now, causes of this revision in joint registries, 9 joint registry, you can see the second number is dislocation. Of course, it is slightly changing now with the infection coming into the picture, that is PJI. Now, this is the New Zealand joint registry which shows in 2010, dislocation rates were 22%. But fortunately, in 2020, dislocation and instability is only 14%, with infection rates going up slowly. Now, epidemiology, if you see the incidence of dislocation, 1 to 3% in the primary total hip situation. The cumulative risk in the first 1 month is 1%. And with first year, it is 2%, increases by 1% for every 5 years period to approximately about 7% in 25 years. It can range up to 28% if it is a revision scenario. And especially if there are prior fractures, intertrochanteric or fractured leg femurs, the range can go to up to 28%. 70% of all the dislocations, they occur within the first month of the index surgery, and 75 to 90% are the posterior dislocations. Now, what are the risk factors involved? There are certain patient-related risk factors, advanced age, dementia. Now, concomitant neurological diseases like Parkinson's, Alzheimer's, cerebral palsy, muscular dystrophy, spasticity. These are the patients are high-risk patients. Even elderly patients having sarcopenia with muscle wasting, there is loss of proprioception, and there are increased chances of fall. So these are the patients we need to be aware of. Drug and alcohol intoxication. Stiff spine, we have already discussed elaborately prior spinal fusion, alternate spinopelvic alignment, all these matter. Female sex, there are some papers which suggest that females are more prone for dislocation, probably because of the wider pelvis, I don't know, but some papers they corroborate that. Now, prior hip surgeries is one of the greatest risk factor or prior fractures for a dislocation. Now, anatomical variations in the hip, if we are dealing with a congenital hip situation, progressive inflammatory arthropathy, metabolic bone disease, AVN, these are having increased chances of dislocation. And of course, psychiatric problems of patient, so decreased compliance in the post-operative restrictions, so that could lead to dislocation. Surgical and procedure or implant-related factors are there. Malposition of component. Directly, the surgeon has to be blamed for that. Excessive anteversion increases the chances of anterior hip dislocation, and excessive retroversion will lead to a posterior hip dislocation. Now, Levinek safe zone. Now, Dr. Sudhir has already killed Levinek. So I do, friends, at least please do not kill Levinek outrightly, because still now 75 to 80% of cases, still Levinek safe zone is important. It's only in the stiff spine and all these spinal pelvic dissociation cases, which probably you require something else. Now, decreased femoral offset, where you reduce the tension, tissue tension and stability, and decreased femoral head-neck ratio. Smaller femoral heads have been also attributed to more dislocation. Extended head-neck column, which causes primary impingement, non-clearance of marginal osteophytes, and of course polyethylene wear, which relates to late instability and dislocation. Now, surgeon-related factors, somebody who is a posterior approach surgeon, again there are papers, meta-analysis by Massonis, 13,000 THR patients, 1 year follow-up, dislocation rates for posterior were 3.23%.
Anterolateral approach 2.18%, lateral transgluteal approach 0.55%. But again, meticulous repair of the posterior capsule and reconstruction of the external rotators, they have brought down the posterior dislocation to almost less than 1%. So that's the good thing. Now, transgluteal approach, lateral approach increases the risk of abductor. The abductor weakness can contribute to instability. And of course, last but not the least, experience of the surgeon. It has shown that with the increasing load of surgery that one does, the chances of dislocation, surgeon-related factors decreases. The mechanism of dislocation, what could be the triggering event? That is very important. We have to distinguish between whether there was an adequate trauma or rather an everyday controlled movement has caused a dislocation. And this latter is very dangerous because that suggests inadequate tissue tension and component malposition. Now, what is the time frame? Early dislocators within 6 months or a late dislocation after 6 months, usually attributed to implant or material failure. Now, mechanism can be at least 4. Malposition, loosening of the femoral stem and acetabular component, contact between the leg prosthesis and articular component subject to joint position, causing a primary impingement, or contact between the bony femur and the bony pelvis, which leads to a secondary impingement, and hyperlaxity of the joint due to a muscular deficiency or lack of soft tissue tension, resulting in abnormally increased translational mobility of the femur. These are the 4 basic mechanisms. And as you can see, increased cup anteversion can lead to anterior dislocation, or increased cup inclination and abductor insufficiency can lead to a superior dislocation, or a retroverted cup can lead to a posterior dislocation. These are the basic mechanisms. Levin's safe zone, we have all gone through that. Now, what important was almost like if you are out of this Levin's safe zone, 6.1% was the dislocation rates. That was as per Levin. And the concept is challenged by Dom et al., Abdel, and we have discussed yesterday also, because the patient-specific functional safe zone and the concept of combined sagittal index, which we are discussing just earlier to this talk, as a replacement for the Levin's safe zone, they have taken into the concept of the spinopelvic angles. Now, causes of dislocation, if you see loosening of the acetabular cup, it's a mechanical failure. And this is extended prosthetic head with collar. Nowadays, we are not using this, which can cause a primary impingement. Use of lip liners also can lead to impingement as well as dislocation. Now, what are the imaging? Normal imaging, that is X-rays, AP, cross-table, lateral views. Now, if you have, they're ready, just a minute or so. CT scan to evaluate component malposition, clinical history taking, documenting the sequence of events leading to the dislocation, whether it's a first-time dislocator or a recurrent dislocator, and neurovascular status, range of movement, all these need to be studied. Conservative treatment. If it is a first dislocator, close reduction under anesthesia, it can be tried in 2/3 of cases where components are well fixed and no obvious malpositioning is seen, and you immobilize with a hip spica or abduction brace or a long knee immobilized. Now, operative management, you can go for a poly exchange in a stable, well-aligned implant with excessive polymer. Revision scenario, 2 or more dislocation with evidence of implant malalignment, implant failure, aseptic loosening, extensive osteolysis or excessive polyethylene wear, and sometimes in very rare situations you require resection, arthroplasty, if there is significant bone loss, soft tissue deficiency, psychiatric patients, and you have exhausted all these surgical options. Now, techniques: component realignment, head enlargement, lateralized liner, trochanteric osteotomy and advancement, use of a constrained acetabular component, and dual mobility. Now, an example to show recurrent dislocation, 56-year-old male patient. This has been managed with component realignment, as you can see here. Revision by component realignment.
I think I've started.
Yeah. So just 1 or 2 slides. Large femoral heads, we will go through that. This dual mobility, the Busquet, large diameter dual articulation. He has combined the low friction arthroplasty of John Charley with the large head concept. Very good. Now, dual mobility definitely holds the edge, especially. Now, revision scenario where you can use it: loss of proximal femur, abductor deficiency, septic debridement, and trochanteric fractures. So, in order to prevent dislocation, you need to identify patients who are at risk. Restore the femoral head offset, larger head if possible, restore the limb length, restore the abductor function, and proper post-operative care and counseling.
So these are my key messages, and thank you very much.
Although ready,
Thank you, Chairperson. Thank you, speakers. So, because we have started with a live surgery, we'll end this session now. So, we are connected to the OT, and I invite next session moderators, Dr. Vikas Kapoor, Dr. Anup, Dr. Mahesh Prasad, and Dr. Sanjeer Patnaik to be on the dais. And over to the chairpersons and Dr. John Mukhopadhyay. He can connect to us. John, sir.
Okay. Can I be heard?
Yeah, you
Can you hear me?
Yeah, can hear you, sir.
Okay, so the case for today is this lady who is around in her mid-40s. She basically had some problems with her eyes, corneitis as well as retinitis some years ago, and was given steroids for as well as immunosuppressive drugs. And she started having mild pain in her hip about 5 or 6 years ago. And this has got worse over the last 2 years and got very severe in the last 1 year. Okay, so you can see the x-rays. Can you focus on the x-rays, please? So you can see the right hip is obviously more involved and is arthritic. The left one has some changes in it, but is still okay. She's not got any pain in the left side. You can see there's a mild abduction deformity, a little bit of protrusio, just probably grade 1, okay? And other than that, everything looks okay. She's quite obese, so she's so fat that we can't feel the trochanter. Although, I mean, she doesn't look that overweight or anything like that, but she's got quite a lot of fat in her pelvic region and thigh region, for which we can hardly feel the trochanter. So we have marked the trochanter where we think it is. Can you see that? So glare nahi hona chahiye na usme.
The glare can be reduced.
Yeah, no, I know, that's what I'm telling them. Okay, is that better?
Yeah.
So, sir, you are doing in supine position with
Yeah, so this is in a supine position with a small sort of bump under the pelvis on the right side. Okay, but not really turning her over to one side at all. It's just to elevate it so it makes it a little easier. And if you can, wo wala Siam picture dikhao. So off kon kar diya. So before we start, we always check that we can see the Siam pictures. Okay, so we did that. Unfortunately, someone switched it off, but he can switch it on again. They'll show it to you. So our incision, this.
Sir, kindly ask the camera person to show all full picture of the patient.
Zoom out करके patient का position दिखा दो. पूरा zoom out करो, okay?
Yeah.
Okay, so you can see that.
Yeah.
इमेज में है ना उसका स्टोर किया हुआ है, उसको फिर दिखाना जरूरी नहीं.
So this patient is in supine with little bit over the GTA area. In this position, we can use the Siam very
bump below the.
Yeah.
And you can see the Siam there, picture there. So you have to make sure that you're getting a good Siam view of the hip. You have to make sure that the pubic symphysis is vertical, okay? Because very often, otherwise, in spite of the Siam, you can go wrong because they have tilted the pelvis and then you are basing your inclination based on what you're seeing on the images, okay? Any other questions before we start? So the incision is basically centered at the trochanter and we extend it towards the patella, lower down and just slightly backwards on above the trochanter, okay? Yeah?
Yes, sir.
So we'll get started. Someone get a forceps for the diathermy and one person keep the diathermy. So she's quite fat, so as you'll see, it'll take some time before we get to the trochanter. So that's our incision going. We might make a slightly longer incision than we normally do, just to retract, please. You can see that I've got a finger in and we are still far away from the trochanter or the deep fascia. Just retract properly. Just, I'm fine. Just concentrate on showing me what I'm doing. Forget about. So now you see how far deep we are having to go before we reach the fascia. Come on, move the retractor up. रत्नेश तुम उसको गाइड करोगे ना, again उधर से देख भी नहीं सकता. So we are still on the fat, still on fat. Retract in the middle, please. You're in the middle up. So you need to get down to the fascia before you start peeling off the. So still you can see how deep the fat is. Okay, so I wasn't exaggerating when I said we couldn't feel the trochanter. Okay.
Almost
So we all
3 inches of fat.
retract again. Deep. Even you need slightly deeper retractors than that. Okay, good. You're finally reaching the fascia here. You can see that white there. So once you reach there, you just gently peel off the fat from that. Just retract here. I need a deeper retractor. It's a deep retractor here. You need to go deep. Gently, excellent. Get it in here and pull like that. Okay, then I just gently, na. Get a deeper retractor, that'll be better. Okay, so try this. Hold this. Take ऊपर कर लो. रत्नेश ऊपर. Okay, so now you can start seeing the fascia. Okay. Come on, change your retractor as I cut, na. Yeah, क्या कर रहे हो? ऊपर चले. So once you get to the fascia, you need to dissect it out a little bit so that you can see it clearly and get some. Okay, down there. Okay. So we are good. पकड़ लो ना. The bleeder there. Yes. Okay. You can see it actually. Not quite. Still there. What's the BP? And what's a normal BP? Huh? So it'd be nice to reduce it a bit more if possible. Okay, so here we are. ऊपर चले जाओ. I want to dissect the fascia clearly. Okay, so now you see, we can see. Can you see that? And the trochanter is actually here. Okay, so the trochanter now I can feel is here. Okay, yeah.
Okay.
Can you see that?
Yes, sir.
I need someone to kind of respond on that side so that I know you are hearing me.
Yes. Yes.
Okay, so then you divide the. Don't go to steep here. Okay, so there you make your incision in the fascia there. Okay, so this is important that you get it at the right level where you have a nice plane. Okay, so there you know, and then when you're going higher up, just feel the thing. You'll find an area where there's no muscle. Okay, so extend it in that direction. Yeah. Show me below. Yeah. Come on. Don't just. Okay, there. You have this deep scissors. Scissors here, Mutha. So very often I extend this proximal thing with scissors, so you get that exact plane for it.
Is this incision at the approximate mid-shaft level, anterior or posterior level?
Yeah, it's at the level of the mid part of the trochanter. Yeah. In this patient, you just weren't able to feel the trochanter. So it's a little bit guided by where you think it is. And we are probably a little behind where we would normally like to be. Okay.
And another trick which I use is the curve of this scissor is because if I'm going to approach anteriorly.
Sorry, Vikas, I can't hear you.
Sir is asking that curve of the scissor, you are keeping it posterior.
Just, yeah, just slightly. Why?
Yeah. So what usually do with these approaches is that I keep it intentionally anterior on the proximity side so that it gives me more leeway on the anterior aspect since I'm approaching anteriorly.
Okay. But what I do is I feel the gap between the TFL and the gluteus and go there. Yeah. Okay. Hang on. And then we put in our Chanli. This is really deep. And it's like, okay, hold. And normally it's not such a difficult job feeling the trochanter. So, sure.
In the bulky patient, it's different, and we need a deeper Chanli. It means goes with
the sound is not very clear for us. Can someone?
The Chanli required would be the deeper blades. In this case, it would have been helpful.
I know this is really.
Yeah, about 5 to 6 inches of fat is there.
We have a bigger Chanli blade. No, we don't have a bigger one. I think
some sets down.
They have.
Yes.
Yeah, I think we have. इसको लगा, उसको हटा दो. Yeah, this is slightly deeper, so hopefully this will do better. इधर देखा.
Sir, there is a query, sir. In this patient, wouldn't it be better if we would have placed it lateral? Means keeping the fat.
It
The lateral position.
Yeah.
Yeah, I mean you can, but we are just comfortable with this position. I did honestly to look at her, I didn't expect so much fat. Okay, this is one of those where she doesn't look that obese, but all her fat seems to be concentrated in this level, huh?
Looks can be deceptive, sir.
Pardon?
The looks can be deceptive, sir.
Yeah, I know. Can be very deceptive. Just retract here.
Experienced amongst us.
One second, nothing. Just come here so I can see the fascia. Okay, that's good. So what I'll do is I'll extend it a bit anteriorly here. Okay, so now we're just getting it a little more. This is popping out. So your mouth was a little behind where it should be. एक सेकंड से नहीं क्या कर रहे हो इसको लगा खोल दो. This is not the greatest Chanli retractor. ऐसे लगा हम यहाँ देख रहे तुम उधर करो. क्या करो उसको सीधा करो.
You can increase the incision a little bit more on the lower side.
Pardon?
Sir, maybe can increase the incision a little more on the lower side, sir, distal side, yeah.
Yeah, we've increased it a bit. Hopefully there's enough. We are a little posterior to where we ideally would like to be. Try externally rotate. Okay, so now you can just retract here, somebody. Yeah. So this, come on, yeah. This Chanli keeps jumping out of place. Doesn't matter, we'll work out something. Okay, hold this. Just retract here like this, okay? And take this that way. So what's important is that you see this part, okay? Where the trochanter, I'll just take off the bursa. Okay, so you can see the trochanteric bursa there?
Yes, sir.
Okay, so we're just going to take that off. If I had known she's going to be so obese, I might not have kept her for the demo. But anyway, that's not a problem. Okay, so now what I want is this to be adducted like this and lifted up a bit. उठा लो थोड़ा उसको.
So the
Okay, so
left arm in extension and a bit of adduction.
Yeah, that's what we are doing.
Adduction. So can the camera person zoom out and show it once?
You just see the position of the leg.
Yes.
Sir, sir, is it testing position of the leg? You can show here.
A little more zoom out, please.
I'm not hearing you guys very clearly. Anup is clear. I can't hear Janki very clearly, I'm afraid.
Yes, sir. Sir, position of the leg, sir, want to see. Yeah.
So it's adducted at the moment. Yeah.
Adducted and extended. Yeah. Yes.
And at the moment it's not flexed any much, but we'll as we go. So now the important thing is to see this ridge of the trochanter, the vastus here, and the gluteus here. Okay.
Camera person, please zoom in.
ऐसे पकड़ो ना, जो उधर से पकड़ो इसको ना.
Please zoom in.
Yeah, just hold this tight, okay? No, don't tilt it. Hold it. Yeah.
Please zoom in here. Yes, sir. Yes, sir.
Yes. You have to keep it tilted like this, okay?
Yes, now it's visible. Please put.
नहीं कर रहा वो निकल जाता है. Okay, we're going to try to इसको ठीक करो. This is a useless chandli. We're just trying to replace the chandli. It keeps slipping out. It's not. हाँ अपना लगा दो ना, उसमें जाएगा.
Sir, can I extend a bit lower incision more? Because there's so much difficulty.
No, this is a problem of the. Yeah, we can. I mean, we don't need more incision there. Let's see. If necessary, we'll do it. इसको निकाल दो ना. We're trying the various applications in the Chanli to see if we can. It's really deep, so there this.
This is really difficult, very quiet.
No, it's not. Yeah, it's okay.
Women's better. Okay, women's.
Can we have hormones in the front, in the neck, basically?
Yeah, we'll do that. We'll do all that. Just. इधर दिखाओ ना तुम लोग यार.
Line it back, please.
ऐसे पकड़ लो. ठीक है. पैर को थोड़ा अडक्ट करो. इसको देखो इसमें. पहुंच ही नहीं रहा है. ठीक है अब ठीक है. Okay, अब लगाओ. ठीक है. A bit better now. Can you see that?
Yes, sir. Now
it's better.
I don't think we really need the incision anymore. It's just that.
I think you proceed. I'm sure you will be able to retract.
Once we take off this, it will be a lot easier. So this is the important part as far as I'm concerned, is this how we take this incision into the gluteus insertion and the vastus slide. Show me the diathermy. Okay, so do we have a, so what I do is like a bit like an omega. So you come here in the posterior part, you go like here, just go past the tendinous junction. And then as you go up, you go anterior, okay? So that you don't risk going into the gluteal neurovascular structure, okay? So we start here. Can you see that?
Yes, sir. It's visible.
Go down there, take this part of the vastus with it. And then as you go up here, and then take it a bit anteriorly here, okay? Just show me this part. No, not that. Just here. Okay, so go a bit anteriorly here, okay? Okay, so that way you're safe from damaging the deep. So you go down to the bone here. And then start peeling this off, yeah? Okay, now as you are doing this, you get the limb to be adducted and externally rotated, yes? पैर को एक्सटर्नली रोटेट करो, धीरे धीरे.
So you are taking anterior 1/3 of the G medius.
Just take it.
You are lifting 2/3 attached to the GT.
Move from there now. He has to take the limb across there. Yeah?
And the limb is gradually being externally rotated, so the
Yeah,
trochanter
yeah, exactly. So just
you are having more visualization of the.
Yeah, so as you do this, you'll gradually see more and more of the trochanter and the neck. So there you're getting some blood from the joint. Obviously, it may be slightly inflamed. Okay, here. So here you see I'm going anteriorly, so you're not going into that part of the gluteus where the vessel will be, yeah?
And it's more towards the anterior part.
Yeah. So just curve that, and that's, I don't know if there's a particular description of. Okay, so now you can see how we are just getting to the base of the neck, yeah?
Yes.
And so once you get across that, थोड़ा सा और ले जाओ. हाँ बस.
So there is a flap of capsule along with the.
Exactly, the whole thing goes together
in one flap.
Okay, so now we are getting to the neck. Okay, so once you get to the neck, you put a lever there. Not quite there. Okay, lever. Okay, so this goes here. Quadriceps. That happening. Okay. Okay, so now we are coming to the neck is here. Come this side. I want a retractor here. Right here.
So you have placed a Homan at the neck shaft and the inferior neck shaft.
Yeah, this is just below the neck, and now we are going to take the upper part of. So you know where we're going to take this off here gradually over that side.
We need to realign the camera. Camera has to come from the right side of Dr. John.
He's trying to get through John's side.
Okay, so
yeah,
let me stop for a moment.
Yes, sir.
So here, lever. So I think you'll be able to see it better now.
Yes, sir.
Okay, so there you can see the beginning of the head cartilage. Yeah.
Yes, sir.
Sorry. Okay, so now इसको ऐसे लाओ नीचे. Okay, so you can see the head moving there.
यहाँ focus करिए ना.
इस पे focus. हाँ, so you can see the head moving there. Yeah.
Yes. Yes.
Okay, so now we'll just take this off a little bit more, and then it will dislocate it.
Sir, your cameraman has to be on the right side of your head.
इधर आ जाओ ना, इस साइड में आ जाओ. तो हम नीचे जा रहे हैं. तुम लोग को रेडी होना होगा मूव करने के लिए. हाँ. So now I'll put one lever on the top of the thing, and then the head will dislocate quite easily. ये वाला निकाल लो. Osteophytes से बोल सर. Okay. अब इसको just hold it.
So would you dislocate the head or would you cut with head in situ, sir?
It depends. If you find it easy to dislocate, we'll dislocate it. If it's a struggle, we'll cut it. Okay, so the advantage of dislocating it is kind of does part of your dissection for you. Okay. But if you are really struggling, then you risk fracturing, so that don't overdo it. Yeah. So now we just need to cut a little bit of the capsule in the front, and it should come out. That's a minute. So again, anterior here, where you're safe. We'll just cut this a bit more. So there are a lot of osteophytes here. So the labrum, part of the labrum. Okay, there you are. It popped out. Yeah.
Yes.
Hey, यार तुम लोग क्या कर रहे हो यार? यहाँ फोकस करें. तो सर से हटोगे ना तुम?
कैमरामैन आप सर के राइट साइड में जाइए.
राइट साइड. सर के राइट साइड में.
अब आप सही जगह पहुंच गए. ठीक है.
Okay, so can we get something like a Murphy's? So now you can see the head is dislocated.
Yes, sir.
Yeah.
It's
Now we get the leg into a 90-90 position. Yeah. Hold this. Okay, so you feel the lesser trochanter, and as Vikas mentioned, you kind of head for about 1.5 centimeters above it. And then we go for the base of the trochanter on the other side. Okay, so since we are doing like a usually a collarless prosthesis, you don't have to plan that abscess. So here I will clear it till so that's the beginning of the lesser trochanter there. Okay, can you see that?
Yes, sir.
So that's the lesser trochanter right there. Yeah, and so we're going to cut. Here's the greater trochanter. We're going to cut roughly in this direction. Okay, now the fact that this is why I prefer this supine approach is when I keep the leg like this, I know exactly the direction in which I'm cutting, and in terms of retroversion, antiversion of the stem. Okay.
Okay.
Okay, now can you see that? Because just focus where I glare कम करना है और थोड़ा zoom करो. Okay, you see that clearly now?
Yes, sir.
Okay, so that's how I'm going to cut it. Okay, so that's through. Yeah. So that's the head out, yeah? Can you see that?
Yes. Yes.
Okay, so take a second. So we are going to keep that head available if we need it.
Yes.
Okay, so now we don't, so now we go for the acetabulum, okay? So the acetabulum position is slightly different from the 90-90. I'll just show you that. इसका पैर का पोजीशन दिखाओ दूर से. हट जाओ इसका जरूरत नहीं. अब ये anterior wall देना. So we use very simple homens. This is a slightly broad homen for the front. Okay, where we elevate this. Okay.
Tended and elevated.
We'll just show you a bit. Huh? Okay, now you can see all this tissue here. We excise that. That for me, please.
That labrum goes now.
That's part of the labrum. We just cut that off. Give me the knife. This is that for me.
Are you doing a cemented hip or uncemented hip, sir?
So what we are planning is for a hybrid. We'll see. So you see a uncemented cup and a cemented stem, most likely. We'll see.
Cameraman, the light inside the cervical site is very less.
Okay, so you need light inside. Okay, and one lever then goes at the level of the tal. Okay, the inferior part. Okay, now you can start seeing the acetabulum clearly. Huh?
Yes, it's visible.
Second, mop dena mop.
would you like to put one behind?
I usually avoid it because what I do is I push this down a bit and that keeps it out of my way. So otherwise, yes, I do sometimes put one behind, but I usually try and avoid that. Okay, now there's a little bit of labrum there, some osteophytes in the front. So we'll get rid of some of those osteophytes at this stage. Okay, so this, you can see that osteophyte there in the front?
Yes.
Artery forceps. So this is all osteophyte here, yeah?
Yes.
So we'll just take off a bit of that. Inferiorly, there doesn't seem to be as much. Okay, osteotome then? Because that gets in the way of your reaming, yeah?
Yes.
Amma? So this bit of the osteophyte will just take off. You can see it's like Nibbler. Come on, guys. Knife. Knife, knife. Okay, so now you can see the acetabulum quite clearly. Can you see that?
Yes.
Just give me a mop. Legit, whatever. Okay, so on a stick. So I'll just clean it out a bit, and now you can see it very clearly. Yeah.
Yeah, it's better.
You can get a good 360-degree vision of it. And now you are ready to start your reaming. Ring curette. So we usually use a ring curette start just to make sure there's no soft tissue, etc., which we want to take out. And here we have to, because of the thing, we are not going to do the initial sort of centering, deepening reamer. We'll start straight with the peripheral reaming. Yeah.
Yes, because this is a different situation.
Pardon?
This is a different situation. You're looking at acetabulum in a normal plane, and you don't have much of
Medial wall to deal with. Yeah.
right?
So give me a 44. 44. 44. Huh. देख क्यों रहे हो वैसे?
Okay, what is the head size measured on the table? The head size
is 42. So we'll start with 42. So it's a small head size. Huh? What's your minimum this thing? Up? 44. So this is going quite easily. That's the inclination, inversion. Okay. See that position? We'll check it again. Give me the next size.
This was size. The reamer size.
Now we'll just bring in the C-arm just to check. We're going for 43. इसको हटा देना होगा देख के निकल नहीं जाए उतना अंदर क्यों जा रहे हो यार थोड़ा बाहर रहो ना okay so you don't want to ream more than that yeah I mean deeper than that you can
we need to see the C-arm picture.
This is the wrong view. Yes, now you're okay.
Yeah, you'll get it. Okay, you see that? Next to next size.
C-arm picture.
Seeing from the top. Yeah. This is the placement. Don't show from the left side. Hello.
Yeah, show me. Dikhao. Okay. Dikhao. I don't want to go deeper than that. We'll use the bone graft. Head को काट के दिखाओ ना. इसको काटो. एक आदमी इसको पकड़ो. So we have a bone mesh which we use to cut the bone. They'll show you how they do that. This is 44. So we're going to 45 now. And now we're beginning to take off cartilage. Yeah. ले लेना. I think we can go 46, 47 at least, if not more.
छोटी वाली picture में CR दिखा रहा है. At this stage, sir, the neck starts coming in the way.
It's still okay. So that's where if you don't cut enough neck,
Sir,
it's a problem.
This is the time when we need to negotiate the reamer obliquely and then it goes inside. So sometimes rotic bone, it takes away a part of the superior or posterior wall.
Oh, no, so what you हर बार नहीं दिखाना है. No, so what we do is we ask the leg holder to pull on the leg a little bit, and that usually gives you the room. Okay. So lift it up and pull it a little bit. It usually gives you that room. But yeah, you're right. You have to be careful that it doesn't get this. So that's. And while taking it out, also you have to do the same thing. Yeah.
Sir, we have lost the picture, lost the videos.
We have here, sir, this is the problem from this side. Just
Oh, you can see it? Can you see it now?
Sir, we have pictures here, sir. We are just connecting on the screen. Yeah.
Okay. हल्का pull करो.
So at what stage are you considering to give the impaction bone grafting?
Yeah, we'll do that. We'll show you that as well. So since we want to lateralize it a little bit. Okay, show me. So we've gone. This is how much? This size कितना है इसका? 48 दे दो. So their cups are in line. So you use the size you ream till. So we'll do 48 and do the trial and then do the impaction grafting. Bone काट रहा है? कहाँ? हाँ तो इसको पहले दिखाना, mesh में दिखाना कैसे करते हैं. Mesh में बोला ना? Bone mesh. हाँ उसके बाद हाँ कार्टिलेज हटा दो. पुल करो, ऊपर पकड़ो ना कोई. Okay, so अब show me now. That's what we are aiming for. Okay, that much.
What size reamer is this, sir?
This is 48. 48. So we'll do a trial now.
And what is the recommendation of the cup size in this particular prosthesis?
Pardon?
This
one is in line. This is the Merrill one, one which I haven't really used very often.
So it's the same size as the reamer?
Same size of the reamer. That's what they tell us. Okay, so that
48 and you have put trial with the 48 trial.
Yeah. So Vikas, I need to get it in a bit more. Vikas. Okay.
Yes, sir.
Vikas. Vikas.
The CR is zoomed.
CR picture देखो.
Zoom में बड़ा वाला picture में CR.
It's quite stable in this.
Sir, don't you feel that if don't you feel that if you have put in a 48 trial, you have already expanded the acetabulum to that level, and you need to go at least one size up in order to grasp the actual cup.
Yeah, but that depends on the sort of each manufacturer has a different system. So they put the trials a bit smaller than the original, yeah. So it depends. So what they say you ream up to 48, use 48 and then use 48, is it? Ratnesh? You know this system better than I do. So Dr. Ratnesh is here with me. He's used this system more than I have. So that's what he says. Okay, so let's see. Okay, so I'm still not entirely happy with this. Because although it's reasonably stable, it's not solid. Yeah? So I will go up a size. Yeah.
A little zone is also visible.
Okay, I'll do it with the next one.
And bone interface.
Yeah, I'll do that. Okay, can you see that?
So the trial did not bottom out.
No, not really, yeah, but it's I'll ream it up a bit more. 49 ka de do.
So will you do just a peripheral reaming?
50 trial karega.
49 करेगा
50 ka trial laga do. So I don't expect it to bottom out fully because I'm going to put impaction grafting and that bit, yeah. So I want it at this level, yeah. Full. Okay, so that's this one. So now we are quite tight here. So I don't want it to go in more than that, yeah.
Yeah, yes. So this is 49 reamer.
Pardon?
Is this 49 reamer?
49. So we'll go trial with the 50 after this, yeah.
So that means we are doing peripheral reaming here.
Pardon?
We are only doing peripheral reaming here.
Only peripheral reaming here, and I might even do 50 peripheral if I find that the trial is difficult to get through. Otherwise, we'll accept this. I've got good cancellous bone here, except in the center where it's cortical. Pull, please. Pull. So you can see the same thing with the trial. You have to kind of lever your way through. Yeah, this is fitting nicely. Yeah, this is a lot better. एक बार दिखा दो. So now you see this is quite solid. Yeah, see that?
Yes.
The whole pelvis is rocking with it. Yeah.
Yes. Yes.
Yeah.
How much is the uncoverage of the trial?
There's no uncovering. It's right till the thing. Yeah. Just the last bit. Maybe just the rim is uncovered. Okay. But it's less than 10%, I would say. And you can see.
This is
sorry.
Perfect. Yes, I should.
Yeah. See the whole pelvis is moving when I do this. See that?
Yeah. It's so you read 49 and you put in a 50 trial.
50, yeah. But I've not hammered it all the way in, so I still have a little bit of room to push. It's tough to get out. Okay. Okay, now we're getting it out. So 50 should go in well. Give me the now we'll show you the bone mesh. So the head bone has been taken the cartilage out. Then we've got those pieces there. We'll put it into this. And then डाल दो ना.
Camera person, the image can be reversed. वो बड़े वाले screen पे ले आइए.
उसको बड़े वाले में डाल दो ना.
Yes, if you put the bone graft, will it, you are trying to lateralize the cup, it will slightly be more prominent.
Sorry?
You put the bone graft, maybe 2 millimeters of bone graft, so slightly it will lateralize the cup. So the coverage of the cup, put it.
No, but so this is cancellous bone, so you can see the gap there on the medial side.
Yes, that is visible when you impacted the trial.
Can you see the C-arm? Can you go on the C-arm image for a second? Ek camera C-arm image pe chale jao. So that's the bone mill, okay? So you'll see how the bone comes out all nicely mossealized, yeah? See that?
Yes.
So it makes life a lot easier.
It's not the fine one, it's I think medium grade.
Yeah, that's okay, because when we do the reverse reaming, it will impact it nicely, yeah?
Yeah, yes.
So before we do that, we make sure that we curate it nicely with the ring curate. Ring curate, you know?
In the mill, we have options of making it to fine, medium and coarse granules or the bone graft.
This one just इसमें अलग size का कि एक size का. So this has that option, yeah?
Yes, yes, that is there. That's just for the beginners. Yeah. So what you need, accordingly, you can use the bone mill for that.
Yeah, exactly. So if you're using it for bone graft,
You need a ring curate now because there is enough removal. All the cartilage is out anyway.
yeah, I'm just doing it to make sure that I've got in the central portion, the bone is so the cortical part is decorticated. Yeah. Yeah. हाँ, so उसको दिखाओ. So that shows the mill sizes so that you can use different sizes, yeah?
Yes.
The bone graft size will be, okay, so bone de dena. Just show us the, andar dikhao. Mop dena, mop. So you can see that it's nicely, see the bone inside?
Yes.
Okay, so you can see it's bleeding bone now.
Yes.
Okay, so can we, so this is the cancellous bone that we are going to put inside. Oops, some of it has dropped out, but that's okay. You got more, you don't need a lot in this particular case. So. बस हो गया. तो रिवर्स रीमर 46, 47 में देना. इम्पैक्टर दे दो पहले. Okay, so hang on, इसको पकड़ो. बड़ा हेड के साथ दे देना. रिवर्स रीमर को ना 47 पे दे दो. हाँ 50 का कप दे देना ओरिजिनल. हमा दो. So we are just impacting that bone graft. Can you just see it now? एक बार दिखा दो.
Yeah, it's compacted.
Sir, is it compulsory to reverse ring?
Yeah, we are going to do that as well.
Is it compulsory?
Not necessary, yeah. Not at all.
I don't think that message, reverse reaming is not compulsory in all cases.
Yeah, you don't have to. This is actually in some ways better. You're less likely to lose bone in the bargain. And it's looking pretty good. So I might just leave it at that. Give me some more bone. So just put in some more bone because that cancellous bone will easily get impacted with the cup going in.
Some will come out with the holes also.
Sorry?
Some of the bone, extra bone grafts will come out through the holes also when you put the.
Yeah, exactly. So we'll do a bit of reverse reaming just to show people it. Reema dena, reema. अच्छा इसको पहले दे दो. Yeah.
Reverse reaming will help to smoothen out all the.
Give me the reverse reamer. So you have to be careful that when you're reaming for the reverse, that you check it. See now she's given it to me in the wrong thing. Okay, she's probably given it in. नहीं वो तो इधर से ठीक करो. इधर से ठीक करो. हाँ. Okay, so always check that. Okay. Because she gave it to me in the intramedullary nailing thing and that way it will not go reverse. Now if you see that, it will go reverse, yeah? Yes. Can you see that?
Yes, yes, yes.
Now it's going reverse. Early on, even when I was pressing both, it was not going reverse. And if very typically the discuss will get you into trouble if you're not careful, huh?
47
Full karo yaar.
47.
एक बार दिखा दो. Okay, so now you see how nicely, and if you ream it in the proper, not in the reverse direction, it will eat up all the bone, yeah?
Yes.
Okay, so now you see how it's nicely impacted the bone there, yeah?
The gap is now vanished.
Yeah, all the sort of loose pieces of bone disappear, but you still have that area covered where you want it till, yeah? Now show it.
Yes.
You don't need to always do so much imaging, but I'm just to show you guys. Dekha? Okay, so now you see how it's exactly in the right place, yeah? Okay, so
cameraman,
Siam picture, please.
Siam picture dikhao. Mop dena, mop ek bar.
Yeah, a nice thin rim of graft sitting around the shell of the stomach.
Okay, so now you can see inside.
Yes, sir.
Show inside. Yeah, kahan gaya camera?
So this is what size? Definitive cup?
50.
50.
50.
Yeah, we did a trial with 50. It was going in okay. Now you can see the inner part is nicely grafted. Yeah.
Sir, did you do trial with 50 or 49?
50. There's no 49 trial. From 48, it's 50, unfortunately. There's no 49 trial, yeah? Okay, so now here's the cup. You have to know the direction of the holes. Okay, so they're going to be at that level. Pull. एक आदमी ऊपर पकड़ो. Please hold the patient को पकड़ो. So this is one of the cardinal mistakes that go. You ask the person to do traction and no one's holding it on top, yeah? And all that happens is the patient comes down the bed rather than any space that you're creating, okay? So see, it goes in quite easily now with the traction, yeah? Okay, hammer. So I'll just check once for the version, etc. I mean, inclination, yeah, looks okay.
See our picture.
दिखा दो एक बार. अब दिखा दो. Okay. दिखाओ.
सीआर पिक्चर को बड़े वाले स्क्रीन पे ले आइए कैमरा में.
अब दिखाओ, अभी का दिखाओ. सब बाहर है. हाँ अंदर करना. अंदर ज्यादा था मतलब. You want it less horizontal or more horizontal?
No, sir, the horizontal is fine. Horizontal looks fine.
Looks okay to me. Looks okay to me. अब दिखाओ. Okay.
Yes. It's looking good.
Okay. Now let's see. That's enough, I think. So now you see how that area is filled in.
Yes.
Okay. So you've got a little bit of uncovering. That is okay, I think. It's quite solid. You can see again the whole thing is moving together. I can't hammer. Maybe it'll go in a bit more. Okay. Okay.
Yes.
Happy with that? Sorry? Doesn't matter. That's okay. Nice solid glass. We'll put in a screw just to.
If you are very happy with the press fit, would you go for the screw, sir?
Let's see, Will. So I think when you've used impaction grafting, it's probably a good idea to put some screws also, yeah? But you don't, I mean, it's quite solid. See that? The whole thing is moving. Focus there. Can you see that? उधर दिखाओ यहाँ पे. बड़े वाले में दिखाओ. The whole pelvis is moving, yeah?
Yes.
We'll put in a screw just. I hate putting in these screws, but we'll put it in. I've not used this device. दिखाओ. रत्नेश ये यूज किया तुम? हाँ? हाँ? नहीं ठीक है. इसके पास तुम दिखाओ. We're going like that, so it should be okay. दिखा दो.
So one of the advantage of CR here that you can see the direction of the screw. In a couple of times your screw may be inside the pelvis. So this can be avoided by using CR adjustment.
But I don't think, Arvind, that is such a big issue because what looks inside the pelvis radiologically is if you are like 2 turns inside the pelvis, you should not really get worried.
Yeah, definitely. But
unless even half the screw is inside,
that is that.
But Doctor, if the screw is directed here, what will you do? Are you going to remove the cup and change it?
No, we have 3 screw option here. So you can choose another hole.
Other holes, yeah. Where you get the hole. Once it's nicely impacted,
no need
to change directions of the cup.
Yeah.
So we are measuring 18, so I'll try and put in 20. So we'll just drill it a bit more. Okay, अब देखा ना?
So So there are 3 holes. Usually the middle hole will take the longest screw.
Yeah.
And the 2 peripheral holes will take at least one size 5 millimeter shorter screws. So if you are getting middle,
20
which is very small measurement, then you should be very careful whether you have dialed it correctly or not. You may have put the acetabular cup slightly rotated anteriorly, and your middle hole, if it is taking 20 millimeters, then definitely one of the screw is going to go, anterior screw is going to go into the
Yeah. And if you're
technical. So middle hole at 12 o'clock position relative to this thing has to be there, and the whole bone can go up to 40 millimeters. It will be such a long screw that.
Yeah, but it varies so much from one patient to another. I think if you're going very short, it usually means that your cup is horizontal, yeah? Is vertical, sorry.
Either that or it is rotated. It may have the correct inclination, it may have the correct antiversion.
Yeah, but if it's
the cup placement is in the rotated position. So even then you can have a shorter screw in the middle hole.
Yeah, true. But if it's vertical, then all your screws will be short.
Yes, absolutely. Actually, a good trick is to keep a finger on the flare of the acetabulum above and palpate if the screw tip is coming out in that area.
Ratnesh, hold this. So this is one part of every uncemented prosthesis which I think can be improved is the screwing in device. I don't know, this one is okay, but every now and then I find it's a real pain getting the screws in exactly right. Okay, that's good. Okay, Deepa?
I think if whatever
yeah, so that's nice. Should we put one more?
25 millimeter and 20 millimeter are 2 safest screws.
Yeah. So this is 20 and it's nicely in the bone. We are going to go for the one slightly posterior to it. Yeah, so this is also 20 then.
20. At least 2. So is the first screw completely seated or you have left it unseated and you tighten it later on?
No, it's nicely seated. I haven't used force on tightening it, but yeah, you're right that before you really use force on tightening it, you should make sure you've got the second screw, otherwise you can rotate it. But this is quite solid. The cup is quite solid. I wouldn't worry too much. So what we do once we've done the acetabulum, we usually take off the chanli, and for the femur, we don't use the chanli. Okay, because you don't really need it, but we'll see. Okay, so now we're putting the second screw. Ratnesh, can you just hold this for me? I like to have both my hands on the screwdriver.
So the other thing which we sometimes I do is, since I know I have a 25 millimeter, 20 millimeter maximum threshold for the screw.
It's nice and tight. See, can you see that? I'm using all my strength. It's holding. And similarly, I'll just check on the first screw again.
So, sir, what is your take on the fact that if you just drill the sclerotic part of the bone for 5 millimeter or 10 millimeter and then put in a 20 screw, would you think it would hold better than completely reamed area and then putting a screw?
Yeah, but I want my cup to get integrated, na? So I want good cancerous bone there. If it's just cortical bone that you have there, you have doubts about it.
What I'm saying is that the sclerotic part, when you are putting in the screw, you are drilling. So the drill goes up to 10 millimeters and then you start going into cancerous bone. So instead of going fully in, you take out the drill at that time and blindly put a 20 millimeter screw.
Yeah. I mean, I guess you can do that, but then you don't know the length for sure, yeah?
Yeah, but 20 millimeter is a safe length, so you can put anywhere. It would give a much better hold to the screw.
But
Only
a couple of times, your screw remains on side. So that is the biggest problem many a time.
36 क्यों चाहिए भाई 32
When your screw direction is little bit eccentric, this
28
gets
नहीं
engaged with the hole with one part is inside the hole and
क्यों ना यार क्या
one
पूछ
part
रहे
of the hand is
हो
just
36
outside.
हमको नहीं
When you are not coaxial with your.
Yeah,
So,
so these two problems sometimes happen.
What he's saying is if you start in the right direction,
Then it will go straight. But even with the partial drilling sometimes it's a problem.
up.
Only partial drilling sometimes may lead to
Completely and
completely drilled. Sudeep, do you completely drill the screw part or it's
Okay, so
partial drilling only or you put a screw?
just clean it nicely. Okay.
A screw inside the cup. Do you drill completely or it's partial drilling? Yeah, partial or complete? Anup, partial or complete?
Complete.
Ramakant? Sujit?
Yes.
It depends on the type of the bone and where you are drilling.
it will depend upon the purpose for the dealing there.
Because of better grip, because we used to do partial drilling most of the time.
So suppose you have, so let's say you're drilling 20 and you're putting 25 screws. The problem is you rotate more, the tips are not cutting.
Artery forceps?
No. You don't have 20 millimeter of sclerotic bone in anything.
No, sir, if you're going into the column and you're drilling 20 and
So
putting
that
a
may be possibility, but in the.
Okay, so we are putting in the liner. So you can match these branches with the sort of
the notches. Sir, is there any?
So this has got a bit of a हाथ लगा लो. Okay, so the posterior superior part sits out a bit. Okay, the rest of it is nicely put in. It's solid. Okay, so we are done with the acetabulum.
Sir, yeah, is this a concentric liner or with a lip?
No, it's in properly. It has a posterior superior lip which is sort of enlarged, so that part stays out, but the rest of it is nicely in. Okay, so you can see the plastic that where the defect is there, it's nicely sat in there. Okay, you can hammer it once more. Just
Question
to...
comes, sir, in a hardening approach, is a posterior superior lip of any use?
Not particularly, but that's what they have in this prosthesis. Okay, so we put it superior more than posterior. That's the only difference. Yeah. So if it's a posterior approach, we'll go put it posterior, superior. This is actually more superior than posterior.
Yeah.
Okay. So upper part anyway is useful to have. Okay. So now once we've done that, then we go to the femur. Okay. So can I have a mop, please?
Not for us.
So how we do that is. So it's really quite a fat lady. Yeah. I hope she is not listening to me. Okay, so one lever behind the trochanter, one at the level of the lesser trochanter. And then what we do is usually, so in this fat person, we'll put a Murphy's like that to kind of
push it up laterally.
90-90 90-90 इसको 90 पे करो ना और इसको ऐसे पुश करो हाँ ठीक है so when you do that can you zoom out and show the position ऐसे ऊपर करो
and being at 90
and we get the this thing
the trochanter is coming out.
Yeah, so when you do that it's there you can and you want to start very lateral on the trochanter. Yeah.
Yes.
The trochanter is here. We'll start almost out here. Okay. See that?
Yes.
Hammer, please.
Would you like to nibble out a bit of?
Sorry.
Would you sometimes like to nibble out a little of cortical bone?
Yeah, we do that. This bone is very soft, so I'm not bothered. Yeah. नहीं इसमें सीमेंटेड के लिए प्लान करते हैं क्यूरेट देना So what we do is we go right laterally here, make sure that we are lateral enough. Even then, like I said, we always check it on C-arm with the trial, yeah. So if there's anything, so that's the advantage of the cemented is you can do minor adjustments even after you've reamed, yeah, which you can't with the uncemented. Okay, so this is the canal finder. Amadena?
You can adjust the version.
Exactly. So when you do your trial, you can do those things. Amadena?
Cemented, you are
Kab wala
committed.
do na? Vikas ki jagah. Amadena? So that's the canal finder. Once you got that, then we start doing the rasting. वो वाला देना ना उससे बड़ा वाला दे. You have a bigger this thing than this? उससे बड़ा वाला है ना? वो दो ना? ये दो ना? So you're going with a slightly thicker reamer. चलो देना. ये कितना है? 0 नैरो है क्या? So this Ratnesh going to sleep. Push together, huh? Not going in fully as it would. Put this up. So when you're rasping, you have to be careful that you make sure it doesn't go into varus, yeah?
Is there a templated size?
Pardon?
Was there a templated size before the surgery? Is
No.
it? Oh, okay.
The problem is, unless you do digital templating or your x-rays are 0 to 0 magnification, the templating is going to be unreliable, yeah? Okay, so that looks like the maximum that's going to go in, but we'll put it in.
And this is the smallest size rasp?
This is 0, that's the smallest size. And so with the striker one, they have a 35.5 and a 33, which we use 35 in most of our patients. They claim that their 0 is a bit thinner than the. I want to get into the second hole at least. You don't want it to break. Almost there. I see it, but I going a little more. Okay, that's it. Trial देना. Trial में क्या है? Minus दे देना. So they have in this size, they have 32 and 36. We are going for 32 because it's only a 50 head. So you want enough polyethylene there. So I don't.
So the 50 liner would only take 32.
Yes. So देना तो standard देना stand. उस sterile but pick it out in the meanwhile. ठीक से पकड़ो ना तो बाहर पकड़. बस हाँ ठीक है. पंच दो. बीच में सो जाते हो तुम. Pick it up. Bring it up in case we need it. ये देना. हाँ निकाल लो ना. ये देना निकालने के लिए. ये निकालने के लिए दो. So we are taking out the swab.
Sir, what is the head size available for 50 liner?
Sorry?
What is the head size available for 50 liner?
32 and 36.
Okay.
In this system, yeah.
Okay, sir.
Striker has 28. We normally use that, but we don't. I'm not a big fan of big heads unless it's for a particular reason, for where you're expecting dislocation, etc. Rotate, ठीक से करो, rotate. Neutral rotation करो. इधर ले आओ पैर. I think I have to try the minus. I'll try the minus. निकाल दिया ना? Yes. देना. Come here on top. It's a bit tight with the 0, so I'm going to try the minus. But you come on, show me, na? Levers. इसको पकड़ लो. इसको पकड़ लो. हाँ. देना. I need the head. किधर भी चाहिए ना, देना जल्दी से ना उसका. ऐसे दे दो मेरे को, अलग से दे दो. देना. This is minus how much? 4. Minus 4. Okay. इधर आओ, बाहर ले आओ, इधर ना, बाहर ले आओ इधर. रोटेट करो ना, न्यूट्रल पे. एक सेकंड. ठहर जाओ. इधर ले जाओ थोड़ा. हाँ, अब इधर आओ. न्यूट्रल करो, अब पुल करो. हाँ, धीरे से पुल करो. Okay, so it's reduced nicely. Pull karo. So there's a little bit of a shock. Check the stability. Udhar le jao. So adduction up to there is stable. Flex. Stable. Abduct. Externally rotate. Pura. So with full external rotation, it's stable. Adduct. And we usi position mein. So even with adduction in full external rotation, it's stable. Yeah, just show that. You see that? Idhar dikha do ek baar. Just show that it is stable. Okay, niche dikha do. So you can see it's not in varus.
Yeah.
Yes, it's more or less straight. And when we put the prosthesis, we can always lateralize it a little bit more if you want on the top. Okay?
Yes, sir.
Can you show the other side? Although the other side is also slightly pathological, so. इधर जाओ वापस. इधर वापस आओ. सेव कर, उसको थोड़ा इंटरनल रोटेट करो ना. Check the lengths. So you can compare the lengths of the two sides also to be sure. Okay, so bone hook. So we are ready for the cementing now, yeah? So we're going to use 0. Huh? Mangalo. उधर ले जाओ. अटैक करो.
32 or 36, sir.
Sorry?
Head style is 32 or 36.
32. I don't feel. I mean, so एक second. For me, I'm actually quite happy even with 28. I don't feel that it increased. See how difficult it's to actually dislocate. External and adduct और हल्का सा pull करो, बहुत ताकत से मत pull. There you are. Huh? So it's quite difficult to dislocate even at this stage where everything is open. Yeah. So if it's so stable here, it is unlikely to be unstable later. Yeah. So I think 36 is good for people who are worried about dislocations, but in most situations, so Chanley did all his hips with a 22.5 millimeter head, okay?
So in this state, how can you assess the limb length?
The opposite side is here, okay? You can't see that, but
in the body from
liver or Murphy's. So the opposite limb is there. We can compare it to that. You check on the X-rays where the lesser trochanter is sitting compared to the opposite side. And if those two things are okay, your chances are you're okay. Yeah.
Yeah.
Okay. So that's more or less done. Now we're going to do the cementing, which should not be difficult. Okay. निकालने के लिए तो. So since we could, in theory, just lateralize it a little bit on top, curate enough. So we'll just do that now. Bone block. So for the cement restrictor, we usually use some cancellous bone itself. वो नहीं चाहिए. हमको इसका जो अच्छा इन लोग के पास वो नहीं है. वो क्या? Zero का length कितना है? So we just use cancellous bone which we push in. That serves as a cement restrictor. वो देना pusher. नहीं उसका length चाहिए ना. ये इसका है ना length. Okay, so that's enough for us. Peroxide swab. अंदर के लिए एक swab दे दोगे? हाँ वॉश कर दें. हो गया उसका काम हो गया भाई. अच्छा इसके लिए कैनाल्स वॉश करने के लिए कुछ दीजिए. वो नहीं लिया. पेरोक्साइड दे दो. So we put in the peroxide swab here. Can you see that? And this is again something that Chanley is described is that you don't take your forceps out. So keep it inside and you will get much more of the gauze in than if you keep taking it out and trying to put it in again. Okay? You see that? Almost the whole length of it is going in.
Yes, sir. It's very obvious. So for the young generation orthopedician, so this step is very important. And nowadays we are forgetting this cementing technique. So it's a start from the preparation of the femoral canal, then the technique of cementing. So coming 5-10 minutes is very important. Focus on the step so that you can replicate the same thing in your surgery also. In fact, in US, it's almost obsolete nowadays. Hardly 2 or 4% doing this cementing in the field or stomach.
Cement gun दिखा दो. So we'll show you how we mix, and so we do have a vacuum mixer, but we don't use it. We have so it's important. So if you have a good cement gun, you can actually put either of the cements in. Okay, you can use even the CMW. We can push it in nicely with the cement gun. Okay, with the one that these companies usually bring for you, if you use low viscosity cement, it works. If you use the regular stuff like CMW, it's a struggle to get the cement through. Cannula. So I'll just show you the 2 or 3 things you should do before cementing. One is make sure the anesthetist is there. So the anesthetist is Dr. Suman and who's Jairaj. So they've been doing a great job with the anesthesia in this lady. We had no trouble with excessive bleeding, etc. We have Dr. Ratnesh with me, who's an experienced arthroplasty surgeon himself. So it's good to have a good experienced person with you. And we have Dr. Ratan and Dr. Adish, okay, who are, one is a SR and the other is a DNB student in our place, okay. So they're helping me, and we have Jyotish, who's the OT technician, and Sister Sarita, who's the OT nurse. Savita, not Savita, wait.
So, and what's the anesthesia being given?
What is the? It's a combined epidural and a general, yeah. So epidural for the post-op pain, and general basically, since we are doing it as a workshop, we don't want her to listen to what we are saying, okay?
And what cement do you use regularly?
So I don't know what they've got, but we normally use CMW. What's the cement? Gentamicin with gentamicin, yeah? CMW only, no? What's that? CMW, DPU ka hai na? CMW. So we are using CMW1, which is CMW with gentamicin. It's a high viscosity cement, but you'll see with this gun, it goes in without any problem, yeah? And can you show them? So there's the funnel which you pour it into this gun, into the, so that all the cement doesn't go out. And now we once, and you have to wait for the cement to stop being sticky, okay? So don't put it in before it is cured, okay? So these are the few things that you have to be, make sure. One is the anesthetist is there, make sure the patient is adequately fluid replaced, BP is okay, oxygenation is okay. Okay, always check this with your anesthetist before you start your cementing. Use a vent, okay? So we always use a cannula to, so that the air bubbles can come out. Next is start with putting in a little bit of cement and then put the rest of the cement. Don't just suddenly blast in the cement. I don't know if that really makes a difference, but as long as your cement is adequately cured, you should not have all the cement implantation syndromes, etc., that people talk about. We use cement for 95-year-old, 100-year-olds, and I should not say it, but we haven't had a problem for a long time. But it's like inviting trouble when you say things like this. But
so, sir, adequately cured means when it is not no more sticky, then we can go on.
Pardon?
Sir, when cement is no more sticky, then only we can insert, no, sir?
yeah, it should stop sticking to your fingers. Murphy's. Okay, push it in.
So message is never use cement in liquid phase. The chances of all the complication of cement happening, because if you use cement in liquid phase. So when it starts, stick to your finger, then only you should apply.
Cannula. So cannula is connected to the suction. We put it in there. Okay, check that. Again, ye dena. Rima. Always check that your block hasn't come back, because sometimes that can happen. So make sure that you're, yeah, so that's okay. And then start cementing. And this is like we put it in. Okay, so it's a retrograde fill. Okay, you just put in a little bit and then start putting the rest of the cement. Yeah? Can someone show the image of the cement going in? So as you put the cement, you start withdrawing it. You also start withdrawing your cannula. So you can, so it's working. Sometimes it gets clogged, then it won't work. You see how all this cement, there's 60 grams of cement, and most of it is going in, yeah? उसको प्रेस कर रहा हूँ एक आदमी. Chalo. So almost 60 grams of it has all gone in. Okay, so this is the Centralizer. Put your thumb here, please. Somebody. Okay, so you push it in as far as it will go without you hammering it. And then the last bit you hammer in. Get gone in till the second. You need to go in that much at least, yeah. Okay, more. निकाल दो सीमेंट, excess सीमेंट निकाल दो. Okay, hammer. Okay, so the second hole is just going in. Okay, just disappeared inside. Yeah, now start. Okay, so there is an instrument which you can further pressurize it. We just tend to use our thumb there because the one which Striker has is quite thick. It doesn't go into some of our canals, but if you can use it, you can use it. So make sure you have a constant pressure on this. Make sure the stem is not coming back out, which it can happen. So keep checking the level. So when you have this space between the prosthesis and the front, can you see that? So can you see that?
Yes.
Between the so that will tell you that you are not in varus too much. If this part is sticking to the lesser trochanter side or the medial side, then the chances are that you are in varus. Okay. सीमेंट को क्या हो रहा है? हाँ? जुड़े तो ना? ठीक है, जब वो निकलेगा ना? हो गया? एक पीछे है. Forceps है ना? आर्टरी फोर्सेप्स बोले थे. So we go for neutral version with the stem, okay? So we are putting antiversion into the cup, but in this we go for neutral version with the stem, and that's so easy because you've got the leg parallel to the ground and you put it at 90 degrees to the leg, okay? See that?
Yes, sir. Yes.
So you know exactly what your version is with your stem, yeah?
So, but the neutral version of the stem is actually an anti-version at the femoral vein.
Exactly. So you don't need more version than that, especially with the anterior approach. So with the anterior approach, you have to be careful not to put it in too much antiversion because then it will dislocate anteriorly. Yeah. Okay. Cement is taking a long time. Obviously, it's been kept cold in the fridge or even the freezer sometimes.
So now you know the reason why we don't do cemented stems.
No, but you just need to have a little bit of patience, Vikas.
That little bit patience is the problem with most of the surgeons after some age. You are showing us the way. We are trying to emulate.
Okay, I think the cement is almost done. It will be in a minute. इसको खोलते कैसे हो? खोल दो. Okay, put ये देना head, neutral head, 0. नहीं minus दिया, minus दो. Pusher. हाँ? हो ही गया, निकाल दो इसको. It's all is done. Artery forceps, please. So now you can see the cement is done. Feel that? Sorry, can you show that? So you just check it's not indenting the cement at all. Okay, can you see that? Yeah.
Yes.
So we are done, and basically the major part of the surgery is done. I sometimes don't even do a trial, but we'll do a trial just once we are sure that things are okay. We don't even bother doing a trial sometimes, but in this case we should. इधर आ जाओ और थोड़ा न्यूट्रल करो, अब पुल करो, हाँ. Let's see the image. So I think now the closure is not a big deal, so you guys can carry on with the program. So you can see that looks nice.
Yes, sir.
Yes.
Okay. Go down the thing. You see the nice cement mantle go down. नीचे दिखाओ ना, बीच में फोन कर रहा है वो बीच में आ रहा है तुम्हारा, ठीक से दिखाओ ना. अच्छा उसका फोटो ले लो.
The first one.
Left side.
Okay, so you see that it's dead center.
Yes.
Good, nice cement. You can see the nice cement beyond it. That's the centralizer where you see that area where it is most radiolucent. Yeah.
Yes.
Okay, so this looks like the appropriate size. Check the root. So we just check stability. You put it through adduction all the way. Can you show this? Show this. Can you position of the leg udhar se dikhao na? So I've adducted it all the way across there. Can you see that?
Yes.
Okay, so we are flexing it all the way. Internal, external rotation all the way. See, even in that position, it's stable. Yeah. And you do the shuck test. Ratnesh, just put your finger inside. So just check that. It should give way just a little bit, which looks okay. Huh? So I think we'll settle for that. I think now it's just a question of putting the head and reducing it. Okay.
Yes. Thank
So
you.
thank you very much. Yeah. Okay.
That was wonderful. Thank you.
Welcome.
Very nice presentation. Now I think I'll ask again to carry on with the proceedings.
So moving on to the next session, that is tips and technique in total hip replacement. And the moderator is Dr. Saurabh Chaudhary. Dr. Saurabh Chaudhary, please.
Ready रहेगा.
Welcome all after this right surgery session for the last session academic talks, and everyone has really saved the best for the last. We all need to be very attentive towards this tips and tricks section. So. So this session is going to be very interesting with all the tips and tricks, and the topics chosen are also very interesting in the sense that a lot of them deal with revision techniques and THR in difficult scenarios like trochanteric fracture, increasingly commonly seen in our practice cases. So I invite the chairpersons for this session, starting with Dr. Sanjeer Patna, sir. Please come. Yes. Dr. Santosh Kumar, Dr. Upendra Prasad, Dr. Madhusudan Kumar, sir, Dr. Manoj.
Hello, Dr. Mahesh Prasad. Kindly join on as a chairperson on the desk. Dr. Sudeep Kumar, kindly join on the dais as a chairperson. And Dr. Khurshid Alam, kindly join on the dais as a chairperson.
So I invite Dr. Ashish Singh for the first talk of this session on cemented cup removal in revision THR.
Very good afternoon to everybody. First of all, I would like to congratulate Dr. Bhadani for wonderful demonstration and showing us what we actually need to learn while doing the cemented total hip replacement. Well, the most important thing while doing a cemented total hip replacement is that the steps, number of steps gets increased. So chances of going wrong is more. But if you talk about benefits of cemented hip replacement, it always bails you out in a difficult situation. So learning how to cementing techniques is very important. But now I am here to talk about removal of established component in revision PHs. So once you put in a good cemented hip replacement, taking it out becomes a challenge if it has to be revised for reasons other than infection. Now, the process of safely and efficiently removing an established component is an important part. You should have an understanding that in 80% to 90% of the cases, where the most common cause in this part of in India is infection, the cement usually comes out. The problems comes in cases where there is a problem of antiversion or abduction angle or some issues where you need to devise a well-fixed cemented implant. So 4 typical steps. Number 1 is exposure, and as a rule, even in revisions, you should have a full 360-degree exposure. In cases where you don't have to revise the stem is well fixed. So you leave the stem. So there is always a problem in exposing the stem, but somehow we have to manage it. Second is the polythene liner removal. Third is obviously in cases of uncemented, the screw removal. And the most important thing is that removing the cement bone interface, because taking out the cup, cemented or uncemented, comes out with a chunk of bone. And then the problem arises because we usually do not have good backup and bone grafts present in the theatre settings. So we have special explant devices. But I'll talk in detail what are the options available. So these are some explant devices readily available of various sizes, and it is manufactured and also being given by the bigger companies, but also in the various conferences we can get the Indian version, cheaper version of the explant devices, which you should keep it ready in case you do lots of revision. So anything is more difficult if you can't see what you're doing. And a 360-degree established rule, exposure is the rule. Put retractors, anterior, channel stems, whatever you want to do, but you need a good revision, good exposure in revision scenarios. Taking out the cemented, the polythene liner in cases of uncemented is easy. You have devices, or you can put a screw just anywhere apart from the hole, and then the liner comes out. That's not an issue. Taking out the screw, if it is, it should come out with not much problems. But the most important step is dividing the connection of the cup to the bone. You just can't pull the cup because it will come like taking out the bone. So number 1 rookie mistake is to attempt to establish component prior to meticulous division of the metal bone interface. Now, several bone conservation techniques has been described to reduce the difficulties in these operations. So one is to use all these curved osteotomes, flexible, malleable osteotomes that goes along between the surface and then the bone bonding breaks. Obviously, all these osteotomes needs to be directed in a proper direction so that things come out in a better way. There are other techniques in which all stable polythene cemented component removal is removed using corkscrew, which is available in the hemi-arthroplasty set. You stabilize with 2 corkscrews and then gradually the cup breaks, and then you have to remove the cement mantle by causing iatrogenic fractures of the cement mantle. This is what I explained, 4.5 mm drill, and then you can break the cement mantle. One method which I found actually is also described for cemented cup removal, but I usually practice it for only uncemented cup removal. So in also, this has been described by Judas, and they say that you keep removing the established component, metal established component, and it comes out. Well, I'm not going to comment much on this, but it is described in literature and it is quoted in one of the journals of arthroplasty. Now, the most important thing is what we wanted to show you in the visual lecture, that how do we take out the screw? So, sorry, the liner. So this is what I was telling, that you drill along the sides of the liner, sorry, in the polyethylene, and once you drill it, if it is not coming out, it very frequently it comes out. There is actually no issues with all these things. And then you have to, with the gouges, this is the explant device. Now there are two ways of using explant device. Number one is the same as I am showing you. You have an explant device which you are actually trying to put it inside and trying to take it out in a 360-degree manner and taking it out. Another option is that this explant device can be mounted on the drill, and then it goes round and round, for which also I've got a video. But that seems a little technically complicated because it will damage the extra vessels and the important structures around the establishment. But explant device as a rule is a good method. And this is what I was talking about, the ZX established cup removal. Now this has been first described in the established system. The same explant device has been mounted on a machine, I mean a drill. And now in the next few minutes, you'll see that this has been also practiced in the normal patient. So point is that it is a wee bit, you can take out the mantle and then it comes out with, but this is on the machines. This is, they are doing it on the live patient. So explant devices can be used in both ways, either hitting it or taking it out. One other method of taking out cemented cup is very simple. With the reamers, you keep on reaming till you get the wire which is there used for molding, and that comes out, and then you break out the cement mantle. But again, I'll get back to the first thing. That important is to break the bone and establish cup bonding. That needs to be broken and to be taken from there. So with these, all these things, division of the established cup is a technically difficult situation, but we need to take it out and take it from there. My take-home message is very simple. You should keep backup good implants, age backup, because sometimes you take out a lot of chunk of bones comes out, and then you land up in not having bone graft or other good options of implants. And as I also told yesterday, together everybody achieves more. It is important to have your team, and you'll achieve more, and you plan for your cases, because if you don't plan, you plan to fail. Any questions?
Okay, thank you, Ashish, for the wonderful talk. So by the time the next talk loads up, please load the next talk by Dr. Navakan. And anyone question pertaining to Ashish's talk, very important that the point Ashish has mentioned, that exposure is the big thing. In any implant removal, exposure is very important. Otherwise, you keep on struggling, no matter what extra beautiful instruments you have. Exposure is very, very important. That's the first thing that Ashish has said. Any particular question that you want, Ashish? Anything? So curve hospitals, probably and rules is very important.
So question is generalized question. We all are doing cemented hip, uncemented hip. Which hip do you find revision is more difficult, whether it's cemented or uncemented?
So it's very difficult. It's very difficult to classify that this is easy or this is tough. Okay, a well done cemented acetable is very tough to remove, and you're going to damage a lot of bones. Okay, so that is very fine. And a poorly done uncemented cup is very easy, it will come up. Okay, but a very good long term uncemented cup, which is like the big cup, which is incorporated, it's also equally difficult to take out. So both are difficult. Okay, but with cemented, you damage your whole bone. Okay, but that does not exclude that you are not going to do cemented cups. Okay, because they last longer.
I want to ask Ashish, if it is possible that you are not able to remove the well-fixed cement, what about cement in cement cup?
Yes, sir. Very good question. And cement division might be described by the Exeter people, both in STEM, and I've seen Dr. John Hope by this lecture in one of the conferences, cement divisions, which I do also quite a lot. And cement cup division has also been described, and it's good. And in cement STEM division, only thing is that you have to use, if you're talking about striker, 44-125 smaller offset, big offset, smaller stem. There's normally the stem comes of 150, but 44-125 stem. So one
Cement stem division we all have done because your experience, because your experience, if you have you done cement on cement in acetabulum? I have never done in the life. You have cement on stem I have done.
So have experience of cement on cement over the femur.
No,
many a time,
let's be focused.
Yeah, many a time removal of the cement from femur is much more difficult in comparison to the acetabular side. So we have experience on that. But cement on the acetabular side, we have hardly cases.
We possibly normally do cement in acetabulum. And when you're revising, even to go within even smaller
Even we can put cement in a protrusion cage and do a cemented cup. Why not in a well-fixed cement? Unnecessarily, you are trying to remove a well-fixed cement. You can damage and you can remove a lot of normal bone.
Yeah, absolutely right. In case of well-fixed cement, you can leave it there and do the cementing over there. There is no issue with that.
No, his question is very, his observation is very valid. You have a cemented socket. Now you are removing the socket, leaving the cement, and putting in more layers of cement, and then putting in another cup. So you are downsizing the cup basically. So if you are downsizing the cup, either you are uncovering the cup further, or you are downsizing the size of the head. So what are you doing? Anybody who is telling us that he has experience in cement cup placement has to clarify this question. I don't have any experience.
So let's start with the revision of the acetabular cemented cup. Most of the time loosening happen at the bone and cement junction. So most of the time you are doing revision for that one.
Anybody has experience with cement cup?
Sanjeer boss?
Yeah, I have given experience of revising a cemented cup.
Sorry, see, cement cup, only when we do it, this has been described by the Exeter people. And when you take out, you're downsizing the cup, making holes. And this is done in morbid patients where there is loosening or problem of the LD version. That's what has been described in the paper. I have done practically maybe one case. Cement stems I do quite frequently. But only one case I have done where there was issue and patient was very old and just. But ideally should not be done. Yeah.
Cannot.
But literature there's no Exeter only.
Again, the literature is whatever is there in literature is for a specific situation which you don't encounter. Here we are discussing the logic of doing a cement on cement cup, and none of us seem to have probably one logic, number two experience. None of us are experienced in doing it.
Yeah, that's right.
Okay, so nice discussion. Let's move on to the next one. Ramadan, please.
Thank you. Good afternoon, everyone. Thank you for inviting me. So this afternoon I'm going to talk about dual data. So it's basically old concept, the new word, new age of life. So as we all know that THR and stability is a common and devastating application. So the most common cause of revision and readmission in the initial 3 months period. Dislocation rates differs in different stages. In primary DHA, it is up to 10%, while in revision scenario, it will be 28%. So as we all are aware of the concept of Leibniz safe zone, and in the last few lectures, we heard that this concept is no longer valid because 58% of the dislocating DHs, they had their established component placed within the Leibniz zone. So It's likely that instability is like multifactorial origin. There can be a patient-related factor, there can be surgeon-related factor, it can be implant-related factors. So we have used multiple options to reduce the instability. We have used large diameter, that is 640. We have used constraint liners, we have used lip liners. So multiple methods have been employed to reduce the instability. They have their own problems. So the new entry, I will not say it's a new entry, it's an old concept, but new use of life. So basically, it was invented in France in 1974 by the two French surgeons, but it was not popularized because there was a high incidence of intraprosthetic dislocation and high wear rate. But after approval by FDA in 2009, second generation of DM cups came to the market, and after that, there is a steady increase in the number of images, both in the primary testing and in the evidence area. So basically, what is dual mobility curve? It's a tripolar curve. Basically, it's an interposition of the mobile polythene liner between the prosthetic head and the vestibular cell. So there are two articulations. One is internal articulation, and other is external articulation. So the inner articulation moves during the normal range of motion, and the movement occurs in the outer articulation during the higher range of motion. And the most consistent benefit has been seen in flexion and internal rotation. So it gives extra approximately 15 degree of flexion and internal rotation. So it's basically based on two orthopedic concepts. Finally, low friction arthroplasty, where a small diameter head provides low torque force in the cell and consequently less wear, and a macifrag large diameter bearing turning. There's large diameter bearing more stable and a smaller diameter head. So basically, dual mobility offers two advantages: large diameter head that increases the jump distance and reduces the dislocation chance. And the dual articulation increases the overall range of motion before the movement of dislocation. So two advantages: reduce dislocation rate and increase the overall range of motion. These are the two benefits of dual mobility curves. So indications of dual mobility curves, mainly in the revision scenario, converging scenario, we are converting a bipolar into THR or a fed PFN into THR, and primarily it is used in selected high risk group of patients. So primary indication, specific groups with high rates of dislocation. There are multiple like displaced fracture knock in elderly, PHI in spinal fluid patients, patient with muscular weakness, poor cognition, obese patient, alcoholics, hypermobile patient, particularly yoga practitioner, patient with elder syndrome. So they are the patients with high risk, I mean, in the high risk group, high risk of dislocation. So they are the ideal testing for primary mobility. So what are the concerns in when we do THR in fracture neck of femur? Always the major concern is high resolution rate, and it ranges from 2% to 20% in different. Because what happens in the elderly with fracture knock? There are multiple concerns like poor muscle power, tendency to repair for old age, poor cognition, osteoporotic bones. So multiple factors need to be considered if particularly knock fractures in elderly. So there are the cases where you can consider, I mean, being able to take up the extra advantage. So these are the examples: 24-year-old female, community of relator, morbidly obese, right fracture knock of femur, uncemented dual mobility curve. Another case: 72-year-old male, alcoholic, obese, community relator, life neck of femur. Again, my part of choice in scenario, unsymmetric. Another case of fracture neck of femur: 70-year-old female with displaced fracture neck of femur, community and later history of CBA, poor muscle tone. Again, in this scenario, this is a dual mobility curve from monitors and it's related dual mobility curve. Other scenarios like a real scenario, we can use it by converting hemi replacement to a THR in cases of recurrent instability and intermediate THR scenario. So this is another case: 70-year-old lady with failed bipolar, broken skull. So this was revised in long diameter stain. EQ was done, and I used the mix and match theory and the rider bull side and dual mobility on the starboard side. This is the 3-month follow-up X-ray. This is 6-month follow-up X-ray. Another scenario, 60-year-old male cemented article was done. He had a history of multiple dislocation and full explained within 1 month of practice. This is the pre-op X-ray, multiple instances of dislocation. I did a cement on cement stem and used a dual mobility cup on the standard side. He was absolutely right in 6 months. They again were able to fall. They had very prosthetic fracture. There was no dislocation. So I fixed the fracture. There was 7 months to stop. Another case, 20-year-old lady failed PFM. There was damage to the sternum. Uncemented trial was removed. So I did a cemented dual mobility cup in this case. 3-month post-op. Another case failed fracture, non-union, 87-year-old male, morbidly obese, non-union fracture. Again, by choice of implanted disease, long weather study on the stem on the global side, and the real will take up on the starboard side. Another case, 75-year-old male stem fracture, and 1.5-year-old cemented bipolar. Again, in this scenario, my choice of implant is balance on the global side, and the real will take up on the starboard side. So there are multiple topics regarding the real mobility. Questions is still debatable, but it has demonstrated an excellent short medium for medium-term result. 98% survivors in 10 years, but still we have to wait for a long-term data to determine 18 year patients. This is a meta-analysis regarding use of modern dual mobility curves in different scenario, and the conclusion is they have demonstrated excellent survivorship, low dislocation rate, and overall low complication rate. So therefore, it can be considered as a safe and effective option, particularly in high-risk population. So extra mobility does not come without complications. So there are specific complications which have been reported in dual mobility, particularly intraprosthetic dislocation, high wear rate because of double articulation, metalosis because of double articulation, psoas impingement because of larger size, and femoral margin. But these complications are drastically reduced in modern and second generation mobility curves. So if you want some objective parameters to assess that which patients needs dual mobility curve, there's an article you can go through it. They have mentioned point system to assess the which are the ideal cases. So take home message is it offers a safe, durable, and effective solution to stability. It's an excellent alternative in emergency scenario, the highest patient population. Regularly using young family patients is critical. Thank you. Thank you for your attention.
Thank you, Ramaka. Next speaker, I'll call upon Dr. Sujit Tripathi. Please put up any particular question about dual mobility cup to Ramaka. Please ask. So it has undergone quite a lot of change, at least 3-4%.
So a lot of people are it's okay. A lot of people are recommending now dual mobility in young neck femur fractures which are very old. After having put in such a large acetabulum down the line 20 years, what will you be left with if you use a dual mobility in a young old fracture?
Personally, I don't use dual mobility cup in young patients, 7 primary DHRs. I mean, my indication is really old patients with high, those falling, specific growth with high disabilities. I've never done primary.
So if you look at where we are coming from, the indication of dual mobility in our situations, we already have large head total lips, 32 millimeter being standardized. We are being almost 70% of us are using 32 millimeters now. Some are varying at 36. Some for some reasons are at 28, but most 70% of the usage is 32. In case you have unstable hip or a revision pending after some time, that is the time when you are looking at a dual mobility as a salvage option. So, but a lot of these new papers in the last 2-3 years, a lot of people are coming saying that use it as a primary sort of implant of choice. That is what I am trying to bring out in this discussion, that primary implant of choice in acetabulum should not be dual mobility cup, because that is where the world seems to be running after, especially the Americans, saying that no, let's fractured neck femur is an unstable situation. You don't know the higher dislocation rates are there. So straight away go and use a dual mobility cup and let the patient jump around, squat, play tennis, etc., etc.
So message is very clear.
Yeah, I mean, the specific group of patients where the risk is high, get used to mobility cups. The data, I mean, certainly, I mean, American population, 2021 data, they have shown 10% use of dual mobility in young patients. So, yeah,
Thank you. Yes, that's good. So this is about intraoperative complications in PHR. And probably we have discussed most of the complications in our presentations and previous talk. So there can be 4 types of complications that we see normally in any surgery. Anesthesia related complications, surgical procedure related complications, comorbidity related complications, and last one is allergy and hypersensitivity reactions. So 2 types we can say. One that we anticipate because of the complexity of the procedure, particularly in case of dysplastic hip, protrusio hip, QC. And second one is unexpected. It can happen even in a normal case of total hip arthroplasty. And that is because of some technical error or some other problem. So this is what we say. The grossly you can say it could be a nerve injury, it could be a muscular injury, there could be intraoperative fractures, leg length discrepancy, hip instability, bone cement implantation syndrome, and achieving a proper implant fixation. So I think these 7 categories of intraoperative complications. Coming to the first one, that is the nerve injury. The overall incidence has been reported in the literature between 0.05 to 1.9%. And shatting is the most common now because most of the people, around 60% of the people, the surgeons still follow the posterior approach. The femoral nerve is seen around 13%, and it is increasing gradually because of the increased use of the DAA, that is called direct anterior approach. And what is the combined nerve pulsing? Because in case of anterolateral approach or anterior approach, also people have seen that they are static nerve pulsing. So combined nerve pulsing, that is the incidence, is around 5.8%. And the rarest one is the obturator nerve pulsing, that is seen in around 1.6%. So if you see, these are the risk factors, particularly female sex, revision surgery, and dysplastic. These are the 3 major risk factors for any nerve injury. And if you tell me that this what the literature is supporting, that most common cause of nerve injury in GHR is probably unknown etiology, and that is around 47%. That is almost 50% of the cases we don't know what has caused the nerve injury. There are 3 mechanisms basically. Either it can be a direct compression because of the hematoma. Sometimes it is because of the bone debris or bone fragments, or it could be because of the cement. It is second mechanism is traction, because in this plastic you are lengthening the leg almost 3-4 centimeters. So therefore, because of the traction on that particular part. And the third one is the ischemia. That means whenever any direct probe, your surgical knife or anything can cut the nerve, or sometimes some instrument can probe on it. So if you see, no, there is no difference in the incidence of nerve palsy between the direct lateral and posterior approach. So it is immaterial whatever approach you are going for. But delayed nerves, there is a features in recovery in suspect hematoma, because if you see that many patients, they were moving their leg, but after certain times you will see that it is decreasing. So in those cases, suspect probably the hematoma is causing the compressions. And in the shatting nerve, it is usually the peroneal component. We all know that. Femoral nerve palsy is less common, but it is gradually becoming more common because of the direct anterior approach. And the superior gluteal nerve, it is usually seen particularly in the direct lateral approach, the Harding approach, when you extend the superior incision beyond 4 centimeters. And obturator nerve, because sometimes we erase the pulvinar crack pad and all these things with a cautery, and we do exaggerated cautery on that side. So it can cause obturator nerve palsy if the middle wall is breached. Sometimes it can lead to obturator nerve palsy also. So if nerve palsy occurs, what need to do? So appropriate radiological imaging, you need to confirm with ultrasound or MRI, and you should do nerve conduction study after a certain period of time, almost 3 weeks or 6 weeks. And if limb is lengthened, there is gross lengthening of the limb, you anticipate and you think that you have excluded all other furthers, probably it is better to go for a leg length well, and that is you revise it. And if hematoma is confirmed, surgery, if the symptoms doesn't resolve within 3 days. But if there is no clear cause, probably it is better to go for a conservative management. So electrical stimulation, close observation and follow-up. And rarely people are doing surgery. That is, I have reviewed only 2 or 3 people where people are even repairing the obturator nerve in case of THR when there is a obturator nerve damage. So this is what people do. Actually, when there is a clear-cut laceration, probably you can go for a nerve transfer in such conditions. Prognosis, if you take 21 months recovery time, only 13% will completely recover. Partial with residual symptoms will be there in 62% of the time, and partial with residual deficiency will be there in 24%. So complete recovery is almost less than 20% of the time. Coming to the next one, vessel injury. I'm not going to tell about the bleeding that we know that tranexamic acid and all this hemostasis, we are going to manage that. But vessel injury is a major problem because you may lose the patient on table. And the external iliac artery and the common femoral artery are the most commonly injured in total hip arthroplasty. The incidence is between 0.2 to 0.3%. And the superior gluteal artery, we have almost, that is, we have seen one case, that's why I'm saying that when you go beyond towards the sciatic notch, probably you will end up in cutting the superior gluteal artery. So don't go 4 to 5 centimeters above the joint line or superior part of the sternum. And the ascending branch of lateral circumflex neural artery, in case of territory approach, it is not a major part, but you can ligate them. So these are the mechanisms of injury. Basically, it can happen with the sharp instrument. Sometimes blunt instrument can do that. Manipulation of the lower limb can also do that. And sometimes because of protrusion of the cup or femur, it can damage the intra-pelvic vascular structures. So if you see the 4-quadrant concept, already it has been mentioned. The safest zone is probably the posterior superior zone, because here the only structure in risk is the sciatic nerve. But people say the death zone is inferior zone, that is the dentist zone, or enteromedial is called as death zone, because you may injure the blood vessel, the major blood vessel like external iliac artery. So management in such patients, if you are on table and if there is a major vascular structure, don't be panic. First of all, you ask for assistance and then immediately apply pressure. If it is a small vessel, you can ligate there. You take the help of the vascular surgeon, and that they should be informed prior, and if you are doing a very difficult case. And the interventional radiologist also, they can do certain things nowadays, which is available in many centers. So this was the case. This is not my case. I've taken it from internet. So where the femoral vessels were damaged while that is operating, and there is radiology people, they put a stent after doing the radiographic contrast. So remember that when you need to place the interventor, it should be intracapsular but extraleveral. So if you are cutting the capsule and putting your liver on the anterior side, then there are high risk of femoral injury. Periprosthetic fracture on this first, I'm not going in detail. So it is more common in the uncemented process than the cemented one, and is very common in the revision scenario. It can go up to 6 to 7%. And these are the risk factors when you use a brace-built implant, particularly uncemented implant, long stem implant, revision procedures, and limited incision technique. Those who do mainly minimally invasive technique, this is the risk factor. So you identify proper, or there should be a proper selection of the patient. Otherwise, you may end up with periprosthetic fractures. So these are some of the technical causes during implant placement, and most of the time we have seen that it is the calcar crack that happen. Sometimes shaft may be penetrated in case of old patients. When we do the broaching or canal finder, it has happened that the shaft is penetrated. And I have seen in few of the sickle cell patients also. There can be cracks between the screw holes during internal fixations, particularly if you are doing THR in case of previously operated DHS patients. You can find that your liver may go in between the screw holes and fracture them. So in such cases, probably the same classification, Duncan and Massey, Vancouver classification basically. I'm not going in detail. And just remember that the treatment is again same. Suppose if it is a calcar fracture, you can just go for your placement of certain wires, like you can go for encirclage wire. But if it is a sharp fracture and your component is unstable, go for a long stem, either at the same time or abandon the procedure and go for the second time. Even with proper, that is after proper tightening also, you can use is cemented implant. It has been mentioned that you can use a cemented implant even fractures and after reduction of all these things. So remember that you have to anticipate these problems. You have to evaluate the osteopenic or osteoporosis fracture, that is fractures particularly. Look for the deformity, look for the canal stenosis, clarify as per the DOR classification, look for the protrusio, and be careful whenever you are doing a THR in case of previous 4D compression, DHS and then. I have already mentioned that if trochanter is displayed, probably the cloud plate is now coming, or the hook plate, when you can go for the TBW. So this has happened to me actually 61-year male, where we did the THR on first post-operative day, we saw this actually. So the stem has sunk, probably it was intraoperative that we missed, and later on we revised it and put a long stem circulation. So this is what we can do. We took the patient again to the theater on the second or third day, and we did the long stem and proper examples. So coming to the femoral shaft, the same thing. If it is an undisplaced fracture femoral shaft, longitudinal crack, protected weight bearing, this patient need to be delayed weight bearing after 6 weeks, and you can circle that, but your implant should be stable. If there is any doubt about the implant stability, probably you go for a long stem, or even you can, if it is not, then it's cost effective to your patients, you can still then use a cemented implant. So these are coming to the acetabular fractures. Compared to the femoral fracture, which is very common in the post-operative period, intraoperative fractures on the acetabulum side is quite common. So if you see any intraoperative fracture, that is more common on the acetabular side. But again, this is very rare. Only one case of intraoperative periprosthetic acetabular fracture is seen in 5,400 cemented PHR. So that is less than 0.02%. So what I mean to say is that acetabular fractures are mostly intraoperative, not post-operative, whereas femoral fractures are mainly post-operative. So these are the risk factors: aggressive rimming, second, using a cup with the rim circumference larger than the nominal diameter of the cup, and if the size of the component is not matching, because some of the implant companies, they may say that it is one side larger, that is when you put the final implant, but there may be mismatch between the trial and the final component. So you have to be highly suspicious inside theater. Sometimes it becomes difficult on the acetabular side because it is totally covered by the soft tissues. But if your implant is not stable, that is compared to your trial implant, then you take the help of the radiograph, or even you can see the ring or the column for any fractures. And if there is any doubt, you just go for a CT scan in the post-operative period and then go for the final procedures. So this was the case in the post-operative epiradiograph. It was seen in the recovery room. There was acetabular fractures. The Judet ileogy also showed the posterior column fractures. CT scan showed the same thing, and again it was revived left long. So the Vancouver classification has been applicable for the acetabular fractures: undisplaced stable type 1, undisplaced unstable type 2, and displaced fractures is type 3. So in such patients, if there is your implant is relatively stable, you can augment with supplemental screw. You can give 3 or 4 screws. But remember, the best screw is kickstand screw. If you are using a multiple cup, probably putting a screw in the ischium is better. So if you have put 2 screws on the ilium, put 1 screw in the ischium, that will give more stability to your component. So either you can go for a supplemental screw, or if the column is totally, that means unstable, probably it is better to go for a plate fixation and put another cup. So I'm not going in detail about the cementing technique. Basically, we have discussed that. So this can happen, and this is the criteria: bone cement implantation syndrome versus hypoxia.
Just conclude this.
Yeah. So these are the symptoms you can say. You can assess the severity of the classifications, and management is again oxygenation fluid and monitoring. Unstable hip, I am not going to tell. You can manage that by measuring the length and your offsets. So what I need to say is that in summary, intraoperative complications inevitably in any part of surgery. One cannot say that I don't have any complication. It is there with every surgeon, and it is more with the high volume of, like I say. Anticipating the problem, reduce the event. That is, if you can anticipate it, probably you can reduce the event, and understanding the treatment strategy to optimize your treatment outcome. That should be the goal. Thank you.
Thank you, Dr. Sujit. And our next speaker is Dr. John Mukhopadhyay. This is the last. And I must thanks to Dr. John, sir. He come on the way after the so exhaustive surgery, a wonderful doing. So we got big round of applause for him. And he speak on encirclage technique for the trochanteric fracture in THR.
So after what Dr. Vijay Bose said yesterday, I don't know if there's any point in giving this talk at all. I'll just show you the basic technique, and just here's a case. This was a 45-year-old lady who had this kind of fixation done elsewhere. And if that fixation wasn't enough, she was followed up at 2 months, 7 months, 11 months, and it was 17 months before the implants were taken out. And she came to us 6 months later. Now, just look at the situation of the bone then. So it was a situation where I was really worried that if I did not do a trochanteric osteotomy, I'm going to break something while doing the surgery. So doing the trochanteric osteotomy gave us a much better visualization. And we did this is a year after that. You can see how nicely everything has settled down. And this is her 15 years later. She's still doing well. There's one wire that is broken slightly, but everything is holding together. And she's an elderly lady, and she never walked very well. She had her abductors all messed up by the time we had her first surgery. Another situation where someone's had a osteotomy with a Wainwright's plate, which has gone on to non-union. Again, here you should be able to put the trochanter in the right place, and here you will need to wire it properly to get it into place. So just to go through the technique, this is from Chandi's book. So because as you can see, we are not doing it that often now, so I couldn't have a video for this. But you've done your osteotomy. Your first wire is a double wire that you pass through the lateral part of the just below the osteotomy. So about 1.5 inches below the osteotomy, you make a hole and you pass a double wire through. You pull it out on this side, keep a artery forceps or something on this side so that you don't pull the wire right away. And then bend this wire laterally so that it's out of your way. Then you make a medial hole. This is almost at the level of the lesser trochanter, which goes from front to back. That's the position of the leg at that stage. Again, you pass a wire there, keep that out of your way. And then you put your lateral wire, which is just below the trochanter, into this cancellous bone here. So it's out of the canal. And you put it from front to back, and you keep it out of the way. Position at that stage, that's where the wires are. This is your double wire, this is your lateral wire, and this is your medial wire on the medial side. Okay, so that's how it is. You then do your trial, you do your cementation, you put your hip in, and then you have to now put the trochanter. You reduce the hip and then put the trochanter back. Okay, so how you do that is you pass, first you hold the trochanter with one of these kind of forceps or whatever. You then pass a wire passer through a hole in the gluteus just above the trochanter and take both the ends of the wire through that hole. Okay, so you've got the wire out through that hole. At this stage, you put the trochanter down, possibly put a wire or a clamp to hold it in place, and then you take one wire through one side of this loop that you have here. So this is the loop. So you bring this two double wire down. One goes inside the loop, one goes outside the loop. Okay, so you bring it like that, and then you tighten that wire. Okay, so you've tightened this loop on the wire, which will hold the trochanter in place. And then you will need to secure your fixation. So you will then have your medial and lateral wire, which you actually pass across each other. Okay, so you put it through the gluteus tendon. Okay, so you take that loop there from this is from the lateral wire. Okay, so you take it across that way. And then you put your medial, so you pull out your posterior part of the medial wire through here, and then you tie them together across each other. Okay, so that's how you do it. So you get a double loop of this wire, which is crossing each other, holding down the trochanter. And then if you tighten the wires nicely, you have to have good wire tighteners for this. There are different ways doing it. Chandi had a special wire tightener. You saw that in the diagram. And then you've completed your wiring once you've done your final tightening, and then it's nice and secure, and then it should really hold it well so that it does well. So a couple of other situations. So here's a lady with dysplastic hips, and on top of that, she had a fracture neck femur on the right side. This was done again, you can see long time ago, more than 20 years ago. And here we did an osteotomy. So here we had to use a 37 size. What's the smallest size in the Chandi? 40. No, Chandi were 40, yeah. So this was a 37 size, which we got at that time. There was a French company which had that available. So that was the largest size we could get in there. So we did the trochanteric osteotomies, got the trochanter down nicely, and we were able to convert this into a bilateral tubular. The other situation is in trochanteric fractures. We saw some examples of very poorly done wirings in some of the cases, and therefore the trochanter was flying off. So sometimes even in a fresh trochanteric fracture with pre-existing osteoarthritis, you're going to decide to do a total hip replacement. So you need to be able to get the trochanter back nicely. So you do your cemented, on-cemented, which tip, whatever you do, but you need to get the trochanter securely wired. So it's important to learn how to do this. And similarly in paid trochanteric fractures, okay, something like this, where you can see the DHS screw has now gone into the hip joint and is damaging the hip joint. You will need to do a total hip replacement, but again, it's important that you get the trochanter back nicely into position. You need to get it back, you need to get it securely wired back to your hip and your abductors to function properly. So I think, although it's not something that we use routinely for our total hips, it's good to be able to know how to put this trochanter back again, because you can have situations where you have an arthroplasty fracture of the trochanter. You've seen multiple situations. Occasionally, as I said, you may need arthroplasty for trochanteric fractures, and you should be able to wire this trochanter back securely. And the other thing is, in difficult situations, not everyone is Dr. Vijay Bose. Sometimes it really helps you in your visualization of the acetabulum to do the trochanteric osteotomy. Okay, so thank you very much. Stop there.
Dr. Sharan, it was excellent. Only thing I just want to ask, what is the size of the wire that you use? That is,
so what we do is we use the thinner wire to go through the double wire.
18 or
yeah, so we use the 1.1 millimeter one, and we use 1.2 for the other one.
Yeah.
Okay.
Another point to ponder here is that while doing the tightening and wiring, it is always better for the assistant to slightly abduct it, so that it falls into its place, so that it can do a wonderful job.
Absolutely, you need to keep the hip abducted. We put in a clamp or even a wire to hold it there when you're tightening the wires. And you have to check it at the end that your wires are actually, very often you can have a slack in the wire and you're not tightening it properly. So you need to check that before you accept the tightening of the wires. Okay.
Any other question from the house?
Then somehow after the implantation of the trochanter plates.
So you can still put in, so if you look at the trochanter, lesser trochanter still allows you to pass in a wire. In the lateral part, you should still be able to pass in a wire. The one that you have to put through the thing is a little more difficult, but you can get a decent wiring with that. So usually it doesn't come off right where you would do your osteotomy. It's a smaller piece that comes off, and you should be able to wire that with 2 wires adequately. Okay.
The double wire part.
Yeah, you can't, because where the prosthesis, if you can put it, yes, but usually the prosthesis will get in your way. Okay. So that's the same thing with many of these trochanteric fractures. You may not be able to pass it the traditional way, but when you get 3, it's a much more secure way.
I think it is important to maintain the abductor mechanism intact. That is more important. And usually it goes to a fibrous union, which is perfectly all right.
No, all of these have healed. Okay, so if you do it properly, it will heal.
Yeah.
And yes, if it doesn't, if it goes into fibrous union, it's still functioning.
Yes, especially in the elderly.
Yeah, but if you do it properly, so these two, so having worked in Wrightington for 3 months, we did it for every case. Okay. Yeah. So at that time, every total hips, except Hardinge had joined, so he was not doing the osteotomy. The rest of the people, Roblewski and Murphy, was still doing osteotomies.
That was a routine actually.
And you very rarely, so you saw breakages very often, but you very rarely saw non-union in the follow-ups. Yeah. So they were yeah.
So what the size of the wire?
Yeah. So we use
1 point.
So the thing is, if you use try to use the 1.2 for the double wiring, it becomes a little difficult. You don't get those. So you tend to use the 1 and then do 1.2 for the other 2 wires. Yeah. But in Wrightington, they had one particular wire. I can't remember exactly what size it was.
For the fiber wire, nowadays fiber wires are available at keyboard.
So none of them you can tighten the same way. Okay, you can't tighten any fiber wire. You tighten it with that. It doesn't work for something like this. Okay, so you can do it for small pieces and instead, if you don't want to show people that you put in a wire there.
Thank you very much. Sure. Then, we have come to the end of the lecture session. Thank you very much.
So, end of this session. So, next, Dr. Jaswindar is here for the felicitation part. And after that, we'll have quiz also.
So do we have Dr. Praveen Sahu here? Dr. Ritesh Rana sir? Dr. Ankur Saran? Sir. Dr. Sujit, can you please do the honors?
Yeah.
Down.
Dr. Nirmal Kumar.
Camera down, bhai.
Dr. Jivendu, please come for the honors.
फ्लैश नीचे कर लो भाई, डिस्प्ले पे तुम देख सकते हो।
Dr. Nirmal Dr. Ashwini Gaurav. Dr. Vinod Thakur sir, to please do the honors. Do we have Dr. Rishabh there?
क्लास नीचे कर लेना भाई।
Dr. Mahesh Prasad.
क्लास 1 नीचे कर लो।
Dr. John Mukhopadhyay sir, kindly.
ऑनलाइन जा रहा है, क्लास कैसे जाएगा? देखो कितना उठा तो देखो।
Dr. Subhash Chandra. Sir, just please stay on. And we have Dr. Saurabh Chaudhary. Please. Dr. Khandelwal, please come on. Dr. Khandelwal, sir. Dr. Rajiv Ranjan from Paras. Dr. Ratnesh. Dr. S. P. Gupta, sir, to do the honors. So we end the felicitation here, and the lunch is open now. And after this, we'll be starting with along with the lunch, the quiz session. Thank you.
So on behalf of myself, and I think all the ladies will come from outside, I just want to thank Dr. John Padhyay, who's been like a senior mentor, and Arvind, and all my seniors who come here, and all the wonderful young faces which I have seen. I did not know so many people in Patna. I thank John sir and Arvind for introducing me to all of you. You are all doing excellent and wonderful work. I'm really so happy to see what legacy this great gentleman is leaving ahead, creating, and even now sort of giving us the pulse and tips. It's a great seat of learning, Patna. And truly speaking, what Patna is giving to the country is probably very underestimated. The understated way in which they present themselves on the national forum. I can tell you that we go to so many meetings together. Dr. John is an icon. You know, he's an icon of everything which we understand in orthopedics. And he is in process of building several of them. And that is the biggest hallmark of a true champion in orthopedics. And I really bow my head to you, sir. It has been sometimes you take the role of a friend, sometimes you take the role of a teacher, sometimes you take the role of a guide, And it's in multifactorial role, but always very quiet and always very humble. I have a lot to learn, and I thank you so much for calling me here again and again. And would be very looking forward to another opportunity, which now this young man kind of always keeps remembering me, and we keep in touch with each other in arthroscopy and other forums also. Well done. Congratulations. You are a great organizer. Thank you, all of you. I met some very new friends, and I remember all of you. Next time, I hope we meet in Calcutta sometime in some meeting very soon. Thank you very much for all the hospitality. Thank you very much.
So, as it's true that all good things must come to an end. So we're coming towards the end of this program, and I'm really actually quite impressed with the kind of enthusiasm and interest shown by everybody, including the faculty and the delegates. It's been a really complete involvement in the whole program, which is something which you don't find very often today. So I think I'd like to thank all the faculty who come from outside and spent their time here. And really helped teaching all the delegates and us. I think we've learned a lot ourselves from listening to all of you. And I think some of the case presentations were really excellent. It's good to see a lot of people are doing all these major surgery in different centers across the state. And I think things have changed quite a lot from maybe 15 or 20 years ago. And it's great to see that. And hopefully that will continue to improve over time. So thank you, everybody. Of course, I must thank Paras Hospital. Dr. Suhas is here, who helped put up the program along with Merrill. Anyone from Merrill here? Who've actually done a major part of the sponsorship for this program. But I think none of this would be of any use without the faculty and the delegates who really make up the most important part of any program. Thank you.
So, which team has to come on the dais, and the rest can join the lunch. At the same time, you can enjoy the quiz also along with lunch. If you are going to
सर थोड़ा
सामने इधर पे
Thank you. चलो वो ही भेज दीजिए, ठीक है, वो तो भेज देंगे ना,
अभी दे रही हूँ सर।
Announcement for the postgraduate students who were the participants for the quiz. Please come forward. Announcement for the postgraduate students who were the part of the quiz. Please come forward. So the results of elimination round are out. The team with maximum marks is AIMS Patna team 1. Mr. Charan Taneja with 19 marks out of 20. Dr. Charan Taneja, please come forward with your team. Sit here and you will play as a team A. The second team is a team NMCX. They scored 17 marks and they will play the finals as team D. Where is team NMCX?